Service Board meeting to order, and Julie, we can start with the roll call.
Christy Blakely,
Present.
Timothy Fox,
Here.
Patricia Gibbons,
Present.
Brigida Hughes,
Present.
Brenda Lacombe,
Here.
Paul Malinkovich is excused, Amanda Moore,
Here.
Jenny Riley,
Here.
Donna Roberts,
Present.
Mike Stahl,
Here.
Mary Young.
Here.
We have 10, we have a quorum.
Good. Before we jump into general announcements, we do have a brand new member of the board, Mandy Moore. Welcome.
Thank you.
Good morning.
Give us kind of a quick overview of where you're from, what you represent.
Sure. My name's Mandy Moore. I live in Westminster, Colorado, and professionally I work as the Nurse Residency Program Coordinator at the University of Colorado Hospital. So my background is in a little bit more of acute care through that hospital experience. But thank you all for having me. I look forward to working with you.
Welcome. General announcements, the date and location of the next Medical Services Board meeting. The next meeting is scheduled to be held Friday, November 14th, 2014, beginning at 9 a.m. here at 303 East 17th Avenue, here in Denver, Colorado, in the 7th floor conference room. It is the policy of this board and the department to remind everyone in attendance that this is a private, that this facility is private property. The capacity of the meeting room is 80. Please do not block the doors or stand around the edges of the room. Please turn off cell phones while in the meeting room as they interfere with the recording equipment. And if the room does fill up, if we could ask staff members to kind of give up seats to other individuals in the audience, that would be great. As you're speaking into the mic, or speaking, please make sure you speak directly in the microphone so we can all hear you. Would be good. And with that, let's go ahead with approval of the minutes from August 8th, 2014 meeting. Do I have a motion?
Yes.
Approval of the minutes?
I'll move approval of the minutes.
Second.
Got a motion and a second. Any changes or? All those in favor say aye.
Aye.
Any opposed? Mr. Fox?
Aye.
Ms. Gibbons?
Aye. Aye.
Dr. Young?
Aye.
Great, all right, we got the minutes passed. Okay, we'll jump into the rules portion of the agenda. We did have one rule, document 1, that was up for emergency adoption. That rule has been pulled from the agenda for this month, but I would like Max and Sarah to kind of come up to the table and give us kind of an overview of what has happened since this was put on the agenda.
Thank you, Mr. President and members of the board. My name is Max Salazar, and I'm here with Sarah Tillman. And we had originally put this rule on the agenda to fix an issue that we encountered with oral surgeons being able to bill dental and medical codes. And originally that was something that was prohibited by our rules, and so we wanted to bring an emergency rule to fix that. But we found actually a systems fix that was able to kind of sidestep that, and it wouldn't require the emergency rule. So I'll let Sarah kind of go into some of that detail.
Good morning. My name is Sarah Tillman. I am the Policy and Operations Specialist for the Colorado Medicaid Dental Program. The reason that we originally proposed an emergency rule was it was brought to our attention about 7 to 8 weeks after we implemented the new adult dental benefit and our new administrative services organization started its management of the benefit, that there was an unintended consequence between the policy and system changes, and that was preventing the primary oral surgeon. I will emphasize that we right now have about one provider who's willing to treat our clients, who is dually licensed as an MD and a dentist. And because of the enrollment rules, he, for several years now, has only been allowed to bill on the dental side of our program. We were exploring several different systems fixes that would alleviate the risk that this was putting our clients in. So I was running down 3-4 different paths at the same time. The emergency rule was one of the paths, and I was very, very happy to find out from my claims systems staff that there was a better fix that did not require an emergency rule. It was literally something we could do within the MMIS, within the current rule, and it would actually take 2 to 3 months less time to operationalize. So we just have a better, faster fix ready to go.
Questions from the board? Any concerns from the providers with this fix, or does it need?
Actually, he's so happy with the new plan, the fix, that he was going to come here today to testify and speak to you all, and he did not feel that was necessary, and that he is confident that we will have him up and running on both the medical and dental side here within a matter of weeks.
All right, thank you very much.
Mike,
We'll let you.
may I ask
Yes,
a question?
Ms. Bynum.
Is there any, Christy Blakely, is there any plan to outreach to other providers so that we increase the number of providers that we have?
Actually,
I
this.
mean, you may not be the person to answer that, but.
No, I would be happy to answer that. This fix makes it more likely that more oral surgeons who are experiencing this problem with the dual licensure may actually see this as an example of wanting to come back to the Medicaid program.
Great, thank you.
There will be a bigger fix in place with the new MMIS. That I can't speak to, but that will resolve a lot of these kinds of issues that programs like mine are running into.
All right, thank you.
Other questions? Lindsay, do you guys want to stay at the table since you have the next meeting? I need a motion for the final permanent adoption of document 2.
I move the final permanent adoption of document 02, MSB 14-07-03A, revision to the Medical Assistance Provider Relations and Dental Program Division rule concerning dental services for children, section 8.202, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Mr. President, this is Pat Gibbons, I'll second that.
Thank you very much. All right, then again, we have Max Salazar and Sarah Tillman.
Thank you again, Mr. President and members of the board. My name is Max Salazar, and I'm the State Plan and Rules Specialist for the department. And with me, I have Sarah Tillman, who's the dental policy expert with regard to this. And we're here to present document 2, MSB 14-07-03-A, revision to the Medical Assistance of Provider Relations and Dental Division Program concerning dental services for children. This is the second reading. I think the last time we took this was back in August, excuse me. And originally, when we brought this, it was a benefit that had already been in existence. We had already been offering these dental services dental services to children. The purpose of this rule was just to kind of further develop and define the amount, scope, and duration of this benefit. And just give more clear guidance to providers as to what the guidance was for providing these services to children. At that meeting, we received a lot of testimony and a lot of feedback on our original version of this rule. And so over the past few months, we've gone back and really worked hard at trying to address all those concerns. Trying to go back and forth between the various providers that had given us feedback and do our best to answer all of their questions and resolve any issues outstanding that were brought up. With that, I think that we did the best that we could, and I think that we did a really good job actually addressing and identifying all those issues, and in addition to some other ones that we sort of picked up. But with that, this is the final reading, and so I wanted to give Sarah Tillman the chance to kind of go over at a high level what some of those changes were, because you'll see that there is a lot of highlighting and stuff in there, but just to kind of go over specifically some of the things that you should be aware of and address some of the specific concerns that were brought up last time.
Good morning again, Mr. President, members of the board. My name's Sarah Tillman, Dental Policy and Operations Specialist for the department. As Max alluded to, and as I'm sure you remember, in August, we did have quite a bit of testimony on the first reading of the rule. I do feel strongly that everyone was in support. They were just here to encourage us to do better. I think we have honored a lot of that, and I have been in touch with all the folks who were here testifying and other stakeholders that have been part of this process now for about a year. It's been underway, and they have had several chances to review the drafts as you see here today, and further changes were even made between that reading and what you see before you today. I would say that the department has been able to accept over 90% of what the stakeholders were asking for and the various clarifications that they needed. I would say that not all stakeholder input was in alignment, so the department did have to make some decisions as to what was appropriate to carry forward at this time. So that being said, I thought I could start going through the 17 pages of the rule, but really try to emphasize the major themes and changes that were made. I just want to start by saying, yes, there's a lot of yellow. Two of the big themes on that, though, is we had a legal review, and a lot of it is just legal language cleanup. Thank goodness I've got really, really great lawyers working here at the department, because I'm not one. There has also been a lot of cleanup just to clarify reimbursement policy, and that's my amazing program integrity staff keeping me honest. So that is what a lot of the yellow boils down to. Starting on page 1, lines 20 through 22, you'll see an additional definition of dental caries. That was at the recommendation of our stakeholders. We did use the American Association of Pediatric Dentists definition as they recommended. We also added on page 2, lines 4 through 8. And if I start going too fast, please tell me to stop. You will see that there is a high risk of dental caries definition, also adopted from the American Association of Pediatric Dentists, with some slight revisions at the request of our stakeholders that the department agreed were appropriate to our program and our risk assessments. The other definition that we were really asked to look at and hone in on is immediate intervention or treatment. That's also on page 2, and those are lines 9 through 10. There was a 12-hour requirement in there, treatment within 12 hours. That didn't work for anyone. The providers, the new administrative service organization, and with the guidance of our stakeholders and our dental director at the administrative services organization, we came up with this definition, and there's nothing about 12 hours because that's not how you properly define an emergency. So that was it for the definitions. If you continue, I'm going to do this in a little bit of a backwards order only because I think what we heard most about back in August was fluoride varnishes. So if you look at page 6, lines 29 through 37, and it actually continues on to page 7.
17 on the rule,
6 of 17, yes.
9 of 20 on the iPad.
Oh, so sorry, the iPad conversion. Thank you. What we needed to do in this section was, it wasn't very clear, just our intent, which is all Medicaid children are eligible for 2 fluoride varnishes a year. It was the high-risk kids we were calling out to be able to access an additional 2 fluoride varnishes a year for a total of 4. So some of that was just cleaning up the language and the structure of that section to make that a little bit more clear.
Providers are in favor of this language now?
Yes, I've gotten full support that, thank you very much, we now understand what you're trying to say to us. So I think it's working much better. And then our stakeholders were also very quick to point out that the ever-important oral evaluations for children ages 0 through 4 still need to be done with a well-child visit, which really falls under these definitions of oral evaluations for children, page 3 of 17 on the rule. Lines 28 through 32. We were aligning the allowances, so we upped it from 3 to 4. So if that child needs that 4th fluoride varnish, they also can get that associated oral health evaluation, and the provider can get reimbursed for both. any questions about fluoride varnish? Because like I said, I know we talked a lot about it. Okay. I think the other big policy section that came up in August, it's on page 8 of 17 of the rule, is interim therapeutic restoration. We talked quite a bit about that. And this was an interesting evolution. The department felt very strongly that, and we communicated this to our stakeholders, that this was something we needed to cover. Our executive director, Director Birch, one of your colleagues, Dr. Malinkovich, the executive director of Oral Health Colorado, Deborah Foote, and our dental director at the Administrative Services Organization really felt that due to the rural makeup of Colorado, the scope of practice that we allow registered dental hygienists to practice within, and the fact that we have 9 counties that do not have a dentist in it, that this is something that is really important to cover. So we took that back to the Colorado Dental Association, who had some initial concerns. And I have support now from Dr. Jeffrey Call, who is the chair of their Government Relations Committee and pens most of the official memos to the department. He is not only on board, he would like the department to find a way in the future to extend this to adults. So I think we're all on board, and we've come to a good place on interim therapeutic restoration. So it is included here in the rule. Dr. Call actually caught the fact that interim therapeutic restoration is limited to primary teeth, baby teeth, and he asked us to include protective restorations as well, because that can be done on primary or permanent teeth. So I think we've covered our bases for our children, and they'll be able to get this service. Other than that, I think there's just a few other things to highlight. In the endodontics section, which starts on page 9 of 17, at the request of providers, the Colorado Dental Association, and at the recommendation of our dental director, we've actually removed some requirements for prior authorization. We have hired an amazing administrative services organization that has proprietary utilization management capabilities that we have never had on our dental program before, because as much as we all respect the MMIS, I think we know it is limited. So thanks to this administrative service organization and what they can do, we feel very comfortable that we can remove these prior authorization requirements, which is much less burdensome for the providers, and we can still maintain a good handle on our benefit and how it's being used. You will find that we've removed the PARS from the partial pulpotomy for apexogenesis on page 9 of 17, those lines 30 through 33. Apexification and recalcification procedures, that's page 10 of 17, lines 17 through 20. And pulpal regeneration, and that's on page 10 of 17, lines 21 through 24. The other big theme I'd like to point out in endodontics that made our providers very happy is we removed any restriction on treatment to second molars for children. While this is appropriate for adults, it's not appropriate for children, and we agreed. And so no references to limitations on that treatment will be found in this rule anymore. Moving on to periodontics. I think the biggest thing to note here is on page 11 of 17, you will see that the department has decided to retain its current coverage of full mouth debridement. This is another point that not all stakeholders agreed on, but at the end of the day, we decided that, again, with the new administrative services organization, we can put rigorous utilization management into place, and we will reevaluate where we're at in a year. After we have a year of utilization and cost data available, this program is new. We've got to get it up and running and see where we're at, and we can make some data-informed decisions in the future and revisit this if necessary. And the other thing that we did in the periodontics section is on page 12 of 17, lines 3 through 11, we did, at the request of all of our stakeholders, clean up the definition of high-risk indicators for periodontal disease. So that should be much easier for the providers to interpret and to put into practice on a daily basis. I'm going to move on to removable prosthetics. I just wanted to point out that Dentures for Children, which is page 12 of 17, lines 24 through 37, the department decided to keep its frequency limitation at 1 every 5 years instead of 1 every 7 years. Again, that just seemed more appropriate. It was already what's in place, and there seemed to be no need to change that. And at the request of, I think, everyone I've already named, we added obturators, which is page 13 of 17, lines 7 through 8. The last section of the rule that I think we spoke a lot about in August and have come to a very good place on is oral surgery, palliative treatment, anesthesia. The entire section has been reorganized and clarified and streamlined, what we were trying to accomplish there, the broad themes is under deep sedation and general anesthesia, which is page 13 of 17, continues on to page 14 of 17 as well. We clarified throughout the entire section that when multiple levels of anesthesia are used, or deep sedation, the department will reimburse the highest level. And this is common practice in the commercial industry and otherwise. So we just wanted to point that out. And we also did remove all references to the use, not for the convenience of the provider, at the request of our stakeholders. And that was on page 13 of 17 under deep sedation and general anesthesia, lines 27 through 28. And the non-intravenous conscious sedation, page 14, lines 12 through 13. We agreed with our stakeholders this was inappropriate policy to put in rule, and there's no need for it to be there, so it has been removed at their request. The other policy that we fixed in this section is on page 13 of 17. We did clarify the policy and reimbursement language around incision and drainage of abscess, and we also seem to have landed in a much better, clearer place with our providers. Those are the big changes I wanted to bring to your attention today.
A lot of work from 2 months ago.
Yes.
Nice job with that. Questions from the board? Questions from anyone on the phone? Ms. Blakely?
I can't find it now, but X-ray, talk me through X-ray. There's one component that is requiring full mouth X-rays, and I'm just curious about, do you know where I am?
No, I'm so
Okay.
sorry, but
So let me do a search and find that then. I was looking and reading, and it made me wonder.
Hold on to that, because we do have one individual signed up for public testimony, so you can have a look through.
Thank you.
And look at that. Deborah Costin? Is here? On this rule? Let her come up, introduce yourself, and who you represent, and your position on this rule.
Hi, my name is Debbie Costin. I'm the Executive Director of the Colorado Association for School-Based Healthcare. And I would like to just thank the Medical Services Board and the staff at HCPF. I did come and testify 2 months ago about this rule because CASBIC has been working for the last 2 years to get additional preventive services benefits for children. School-based health centers are all about prevention, and basically prior to this rule, preventive services were limited to kids under 5 years of age. This rule changes that so that children 5 to 21 will be eligible for preventive services, screenings, fluoride varnish application, etc. And because we see many of those school-age children in school-based health centers, in fact, thousands of Medicaid enrollees, and especially the newly enrolled children, many of them have never seen a dentist. So now our medical providers will be able to screen those children, apply fluoride varnish, and coordinate their care so that they get the dental services they need. So basically, I just wanted to say that all of the things that we brought up 2 months ago have been resolved, and we appreciate HCPF's work on that, and we are now in favor of the rule, so we hope you approve it today.
Thank you very much, Debbie. Appreciate you taking the time to come in.
Yes, I did. It's page 5 of 17, and it's 29 through 33, and I misread it. So I retract my question.
Okay, great, thank you. Is there anybody else who would like to testify on this rule that hasn't had a chance to? All right. Any other questions from the board?
Just great work.
We've got a motion and a second for document 2. All those in favor of final permanent adoption, please signify by saying aye.
Aye.
My list on the phone. Dr. Young?
Aye.
Mr. Fox? Aye. Dr. Gibbons?
Aye.
All right. We have approval of document 2. Thank you very much.
Thank you.
Very nice job outlining the changes on that.
Thank you.
All right. A motion for document 3, please.
Move the final permanent adoption of document 03 MSB 14-06-25-A, revision to the Medical Assistance Health Program Services and Supports Rule concerning amount, scope, and duration of ambulatory surgery centers, section 8.570.3.D, incorporating, I think we should make this more complicated, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second. Very good, thank you. We have Anna
Lukács.
and Matt Calusi.
Excellent.
One for two, right? Welcome. Can you give us an overview of document 3, please?
Good morning, Mr. President, members of the board. My name is Anna Lukács. I am a policy specialist with HICPUF, and I'm here to present Rule MSB 14-06-25-A, revision to the Medical Assistance Health Program Services and Supports Rule concerning amount, scope, and duration of the ambulatory surgery centers, section 8.570.3.D. And this is the second and final reading of this rule. We brought it to you to incorporate the language that we had in the benefit coverage standard that was before incorporated by reference. We had 3 changes to the version you last saw. We deleted, we added as an ASC. Let me get to the page. When we say 1 of 4, thank you. We wanted to mention that when the license is issued by Colorado Department of Public Health and Environment, we wanted to make sure it's an ambulatory surgery center. Next, we removed the line where we required a total of 90 minutes operating time. That is no longer
Mr. President,
Yes.
I'm having trouble hearing on the telephone.
Okay,
I
thank
wonder if the
you.
microphone could be moved a little closer to her?
We'll do that. Thank you.
Is this better now? Okay.
Yes, I think so.
Good. So as I was saying, we removed the requirement for a total of 90 minutes operating time. This is no longer a requirement by CMS, by Centers of Medicare and Medicaid Services. And we also removed the 90 minutes duration when we talk about the anesthesia, local, regional, and then general. And with that being said, we do have an R page today.
The board all has the R page in front of them, I believe. You can kind of just review what is on the R page from what was sent out.
On the top of page 2 of 4, we removed the first line saying general anesthesia of 90 minutes or less duration when we only intended to remove of 90 minutes or less duration. We still need general anesthesia in an ASC.
So it's just leaving in
General.
line 30, that is number 2, general anesthesia?
Yes.
That's the only change on the R page?
Yes.
I'll move the approval of the R page.
motion, do I have a second?
Second.
All those in favor of approval of the ARC page, please signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Givens?
Aye.
Mr. Fox?
Aye.
All right, the ARC page is approved then. Any other parts of the rule you want to bring to our attention?
As I mentioned last time, the Colorado Department of Public Health and Environment is considering revising their rule regarding licensing the ambulatory surgery centers. They're looking at combining this license with convalescent centers, which are usually attached to an ASC. They haven't brought the rule yet to their board, so we are pending their decision if this is going to impact our rule or not. So in the future, we might bring this rule back or not, depending. But right now, it's as good as their rule.
Questions from the board?
So this is Pat Dennis. I have two questions.
Okay, please go ahead.
First one is the eligible client. I tried to pull up the document. Could someone review who the eligible clients are in this policy? And then the second question I have is, it looks to me like non-covered services are emergency, life-threatening in nature. So my question is, if there's a need for escalation of care, for example, resuscitation, till the person can be transferred to another level of care, where is that covered?
Mr. President, members of the board, all the Medicaid clients are eligible for ambulatory surgery center services, to answer the first questions.
So
First
all
question.
ages then?
Pardon?
All ages?
All
Yes,
ages?
yes, all ages, yeah, there is no age limitation.
My question was related to, I guess, specifically age restrictions, if this is children as well as adults.
Yes, exactly, we do not have an age restriction.
Okay.
And to answer the second question, in cases where a different level of care is needed, they can transport the patient or the client in this case to a higher level, like a hospital. And we would cover that under the hospital benefit.
Okay, thank you very much.
Yes.
Any other questions from the board? Nobody has signed up for public testimony in document 3. Is there anybody here who would like to testify in document 3? Seeing none then, we have a motion and a second for final permanent adoption of document 3. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Givens?
Aye.
Mr. Fox?
Aye.
All right, we have final permanent adoption of document 3. Thank you very much.
Thank you.
Moving on to the initial approval agenda, if I could have a motion for document 4, please.
I move the initial approval of document 4, MSB 14-07-28-B, revisions to medical assistance health program services and support tools concerning the bariatric surgery services, section 8.300.C, incorporating the statement of basis and purpose and specific statutory authority contained in the reference.
Second?
Second.
Thank you. We got a motion and a second for document 4, and again, we have Anna Lukacs and Matt Calusi here. Welcome.
Good morning, Mr. President, members of the board. My name is Anna Lukacs. I'm a policy specialist with the department. I'm here to present a document MSB 14-07-28-B, revision to the Health Programs Benefit and Operations Hospital Services Rule concerning bariatric surgery, section 8.300.C. We are bringing this rule today because we had incorporated by reference our benefit coverage standard, and we are incorporating all all the wording in the benefit coverage standard into the rule, so we will not have the reference anymore.
So is that the main piece, is taking it out of reference and putting it?
Yes, we took out the reference that referenced the benefit coverage standard, and then everything that you see on this rule has been added from the coverage standard.
No changes coming in at all?
No.
Questions from the board? Yes, Ms. Brennan?
Thank you, Mr. President. I'm just wondering, we have a couple new members of MSB, and is it worthwhile mentioning why we're pulling these rules out of incorporation by reference and back into the rule?
Sure, would you like to give us that update?
Yes, as long as I could do it somewhat informally.
Yes.
Because it's been a few months since I talked about it.
Mhm.
But originally, the department didn't want to have all of our rules, have all of this detail about benefits that we cover in rule, because the rules are so legalistic, and they're very long, and we hoped that we could just basically have our benefit standards written in plain English, in a sort of a benefit manual, essentially, and then just incorporate those benefits by reference into our rules. But the legislature, I can't remember the name of the committee, what is the name of the committee, They said you can't legally do that. So now we're having to go back and take all of the benefits out of the benefit standards and then put them back into the rules. So, we really wanted to have the benefits in a benefit standard because it's easier for providers to navigate and to read, as opposed to having to go through our entire volume of rules. So, in this example, it's just very simple, where basically we had pulled it out of rule, put it into the benefit standard, now we're pulling it back into rule. So you're gonna see more of these every month, as our staff are able to go back and rewrite, these standards into the rule language, essentially. So, any other comments or questions to help fill that in? Okay.
Nice job.
Yeah.
Nice job. Yes.
Could you, I'm getting emails that people aren't hearing us at the table. So,
Okay.
just speaking. Thank you.
All right. Reminder for everyone to try to speak into the mic, bring it close. Very good. Any other questions from the board? Do we have anybody signed up for public testimony? We don't have anyone signed up for public testimony on document 4. Would anybody like to sign up for public testimony? Seeing none, we have a motion and a second for approval, for initial approval for document 4. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good. We have initial approval of document 4. Thank you very much. Moving on to document 5, if I could have a motion, please.
I move the initial approval of document 5, MSB 14-07-28-C, revision to the Medical Assistance Health Program Services and Supports Division rule concerning dialysis treatment centers, section 8.310, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion, a second for document 5. And again, we have Anna Lukash and Matt Calusi. Matt, you're having it easy today. I just want to point that out.
Yes, sir.
Okay. If you'd like to go ahead and explain document 5.
Sure. Good morning again, Mr. President and members of the board. My name is Anna Lukac. I'm a policy specialist with the department. We are bringing the document MSB 14-07-28.C, revision to the Medical Assistance Health Programs Benefits and Operations Rule concerning dialysis treatment centers, section 8.310. We are incorporating with this rule the language that we had in the benefit coverage standard that was previously approved by the board and incorporated by a reference in the rule. So just as we did with bariatric earlier and ambulatory surgery centers.
Again, no changes at all coming out from reference to the rule?
No.
Questions of Ms. Blakely?
Christy Blakely, I'm wondering if there's a age limit on this, specific to home care and dialysis?
No, there is no age limitations.
Okay.
If we do offer in-home dialysis, and the dialysis treatment is responsible for training the client or the caregiver.
Okay. All right.
Yes.
All right.
My only question when reading this is the very last line of the non-covered services, the only examples are slippers and toothbrushes. Are those common things that come up in these situations?
Yes, because they spend a lot of time in the treatment center,
Mr.
so
President, this
sometimes.
is Pat Gibbons. I'm having a really hard time hearing the testimony from Nana.
Okay.
I'll try to speak louder.
Sorry.
I'm not sure if we can turn off that microphone at all. either.
Use your outside voice.
Cause some feedback in the room.
Okay. All right, thank you.
So the answer is yes, it's common because they spend a lot of time in the treatment centers, and they want to feel comfortable.
Any other questions from the board? Do we have anyone signed up for public testimony for document 5? We don't have anyone signed up. Would anyone like to sign up for document 5? Seeing none, we have a motion and a second for initial approval for document 5. All those in favor signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
All right, we have initial approval for document 5. Thank you both very much.
Thank you.
Thank you.
Moving on to document 6.
I move the initial approval of document 6, MSB 14-05-06A, revision to the Medical Assistance Managed Care Contracts Division rule concerning billing procedures for certified health agencies, section 8.564, incorporating the statement of basis and purpose and the specific statutory authority contained in the records.
Second.
A motion and a second, and we have Richard Delaney here. Speak.
Yes, good morning, Mr. President and members of the board. My name is Richard Delaney. I'm a policy specialist at the Department of Healthcare Policy and Financing, and I'm here to present document 5 or document 6, revision to the Medical Assistance Managed Care Contracts Division rule concerning billing procedures for certified health agencies, section 8.564. This rule change is part of our effort to convert from the Colorado 1500 claim form to the CMS 1500 claim form. That conversion will take place December 1st, and this was the only place in our rules where we specifically mentioned the Colorado 1500. At this time, we're removing that reference and referring back to the rules regarding how claims are to be submitted. So in the future, should for some reason we change from the CMS 1500, we won't have to change this rule again. It will automatically change depending on how the state requests providers to send in paper claims. This is a project that has been advocated by stakeholders for years. It just makes it easier. The CMS 1500 is the standard claim form in the nation, so it'll help for out-of-state claims as well as those providing services in state.
Questions from the board? Questions from anyone on the phone on this one? Public testimony? Nobody has signed up. Would anyone like to sign up for public testimony on document 6? Seeing none, we have a motion and a second for initial approval of document 6. All those in favor signify by saying aye. Aye. Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good. We have initial approval of document 6. Thank you very much.
Thank you.
Moving on for initial approval of document 7, if I could have a motion?
Move the initial approval of document 7, MSB 14-06-4-A, revision to the medical assistance home and community-based services, home modification rule for persons with brain injury waiver, community mental health supports waiver, spinal cord injury waiver, and elderly blind and disabled waiver, section 8.493.3, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Second.
Second, great, and we have Colin Laughlin here to present.
Good morning, Mr. President, members of the board. My name is Colin Laughlin, and I'm the Brain Injury Waiver Administrator for the Department of Healthcare Policy and Financing under the Office of Community Living in the Long-Term Service and Supports Division. Getting used to saying that. As part of my duties, I also oversee the home modification benefit. The home modification benefit is available to individuals in all of the waivers that Ms. Blakely mentioned. And it allows individuals to receive modifications and alterations to their home to allow them to remain independent in their home and in the community. So we're actually just here today to include an additional increase or an increase to the overall lifetime cap that is available to individuals on these waivers. This is to meet a legislative appropriation that occurred this last legislative session. The funding that we received from them allowed us to increase the cap by $2,000 or $2,500. What we're looking at doing as well as part of this rule change is another slight alteration to provide clarification to our case management staff across Colorado that allows for individuals to receive repairs or get repairs on their modifications. For example, if someone had a modification done to their home 4 years ago, with the weather that we have here, oftentimes it will fall into disrepair. What was unclear a little bit in the rule and certainly to our case management staff was that people can get a repair done to that modification, assuming they still have money available for their lifetime limit. So we're just providing that clarification. We're increasing the overall cap. So throughout the rule, anytime you see $10,000, that's changed to $12,500. In addition to on page, the first page of the rule, so 1 of 5 of the rule, 8.493.2b is the clarification around repair. Otherwise, it should be noted there's actually a lot going on with this benefit right now. As another piece of this last legislative session, we had actually received some money to transfer oversight and quality control to the Department of Local Affairs, Division of Housing, so they could actually oversee this benefit. It makes much more sense than Medicaid policy people overseeing a contracting benefit. So we're excited to have them exercise some more quality control. We're anticipating that kind of formal interagency agreement to occur yet this fall. In addition to that, we are going to be picking up some robust stakeholder meetings this winter and kind of looking at an overall redesign of the benefit. Since taking over this benefit, I've heard quite a few providers, clients, other interested parties kind of talk to some of the concerns they have about the lag in time between when the assessment occurs, when the modification happens. Also some really simple things I think can help streamline the program. We're looking at trying to work with our OTs and PTs to make sure that when they go out and do an assessment, that individuals are made aware of kind of in descending order what are the most important things for them to remain safe and independent in their home. And oftentimes now that's not done. They're just given a list of all of the modifications that they think are necessary. And the contractor and the client aren't oftentimes in the position to kind of really know which ones are going to be the most helpful for again, remaining independent in the home. So with some slight changes like that, also looking at some broader changes to make sure that the systems issues can kind of churn a little bit quicker to make sure that people aren't waiting as long for the home modification, trying to make sure that we're not running into a situation where someone can't get out of a facility into their home. Some work around the Colorado Choice Transitions program. I know they've already done some great work on that, so we're hoping to emulate that. But there's a lot of stuff that we're intending on doing with our partners over at the Division of Housing that we think will kind of tie in very nicely with this. And quite honestly, why I know how to swing a hammer. I don't know how to do any contracting work and what is of good quality, and so we're very excited to have that happen. A quick other note, I did receive one public comment for this. It was in regards to someone supporting the increase, and then they also requested that an OT who specializes in working with individuals in the disabled community weigh in on modifications and recommendations. And I think that kind of goes to the piece where we want to make sure that our OTs and PTs really understand the program and understand how it's implemented. And so we do intend on having some robust training both with case management and our OTs and PTs.
We've all received that written testimony as well. Questions from the board? Document 7?
Sorry, I guess.
Blakely?
Christy Blakely. Okay, so at one point in this rule, it talks about removing that limited lifetime cap, but then it goes back, okay, so at the very beginning, it talks about removing, that the goal was to remove the lifetime cap. So talk me through the lifetime cap issue.
Are you speaking to the regulatory analysis?
Mm-hmm.
So that, unfortunately, we probably just overlooked that. That was, the intent was to, in the rule, not have an indicated lifetime cap. However, what we know is that we're working with stakeholders to continue to, explore the possibility of expanding that cap further. And so we didn't want to put an actual number in there. However, because case managers and others look to this rule for the definitive amount, we thought that we'll wait to do that until we redesign the benefit kind of at large. And so that's a process we expect to do this winter into the spring. I also know that in speaking with other stakeholders and external groups, there is obviously an interest in removing the cap altogether or pushing it out further. The department's certainly willing and interested in looking at that, and I think we'll work together with stakeholders to try to figure out what the best approach is to make sure that we're being both fiscally responsible and ultimately allowing people to live as independently as possible in their homes.
May I ask a follow-up? So you said, are stakeholders on board with waiting until there's a full revision?
For removing any mention of any amount in the
Yes.
limit? Yes, I think, again, this rule, we know that there are other issues with the home modification benefit.
Yes.
I don't think that's a mystery to
No,
anyone.
it's not a secret. No,
Right.
that's correct.
So I think that this is, really, this change is just to allow people to access the money as quickly as possible. And our intent has always been in our conversations with a variety of stakeholders, whether that be clients or providers themselves, who've been interested in this for quite some time, has been that we will absolutely open this rule up for stakeholder comment, public input, and really kind of have a collaborative process to redesign the benefit.
Okay, thank you very much, I appreciate it.
Do you have an anticipated timeframe right now when we may see it back with?
I would imagine sometime this spring. I think what we'd like to do is, as I mentioned, we're moving towards, we're having some systems issues with some of the new core stuff with the state to get the agreement with the Department of Local Affairs, Division of Housing, interagency agreement signed. What we'd like to do is get them involved, have them at the table, kind of co-leading these groups, because they really understand, what this benefit should look like in the oversight of it. And then we also know that there are a lot of providers that are interested. I would anticipate once we kind of come to a conclusion with that process, we'll start those in earnest, and so I'm hoping this spring.
Thank you. Other questions from the board? Anybody on the phone? Do we have anyone signed up for public testimony? Dan?
Sorry, I'm trying to get the sound.
Can't hear me? I'm eating the microphone.
Maybe that's the problem.
Yeah.
Mastication.
Okay, we do have one individual signed up for public testimony. Can you hear me better on the phone now?
Yes, I can hear you great.
Very good. We have Josh Winkler here. If you could come forward, you are forward. Introduce yourself, who you represent, and your position on this rule.
Hi, you guys. Most of you know me already. It's been a while since I've been here, but glad to see everybody again. And I'm actually this is the perfect rule to quote Mark Simon and say, I'm going to represent myself on this one. I'm Josh Winkler, and I represent Josh Winkler. I think, as Christy said, it's no secret that there's been issues with the home mod program for a long time. And so I'm really glad the department is working on this. I do have a couple questions about it, though. I know Pat Stedman is the one who brought this up legislatively, and it was his intent to see it doubled from 10,000 to 20,000. And I know there was a budgetary concern there even for him. Was there a budget analysis done to come up with the $2,500 number?
Yes, absolutely. So, and thank you, Josh, Mr. President, members of the board. Yes, so what, and I could kind of explain the projections, and if it doesn't kind of add up or make sense at the end, please let me know. And I can maybe have someone from budget come next time if there is still concerns. That said, what we're looking at and what we have across all of our waivers, so the 4 adult waivers in long-term service and supports, is a projection of about $5 million for this benefit for this next upcoming year. What that looked like with the additional $500,000 that was made available in the general fund, and then the federal match that was added up to be about a little over $1 million, was about $6 million total for the projection. What we had to do in this, in talking with our budget analyst, he did say it was somewhat kind of tricky. We had to look at individuals who've never utilized the benefit before, and the expectation of those coming onto the waiver that would now have the ability to exercise the lifetime limit of 12.5, in addition to people who are already at the limit, so that additional 2,500. People who may have already spent something but didn't maybe have another larger amount available to get up to 12.5, but now they do. And all the people that haven't even accessed the waiver yet. So we had all of those data points, and we had to trend them out for the rest of the lifetime of the waiver, which is 4 to 5 years, depending on the waiver. And what we came up with in the highest kind of feasible amount that we felt comfortable putting, with all of that said, was $2,500. And so while I know that the intent, and certainly within the long bill, it states that the intent is to raise it to $20,000, with the money that was made available to that, it just was not feasible budgetarily.
I have a follow-up question on that. Christy Blakely, so has the department maxed that previous to this year?
I'm sorry, I'm maybe not understanding that question.
And now I'm going to try to say it again better, okay? We'll both work on this one. In the past, the data in the past, has the department utilized all of the money annually?
The projected money?
Yes, the money that was available, were they going to the limit on that?
Yeah, so that's a great question, and I don't know the exact answer like way back historically.
Okay.
I can only speak to the last few years, and that is that we have been gradually approaching, and what we've having to redo a lot when we amend our waivers and have new agreements with CMS is the projection for the home modification benefit, because what we do see is more and more people utilizing the program. Obviously, I think when you're talking about a home and community-based waiver in general, the cornerstone of home and community is the home. And so having people utilize that benefit is something we're very interested in, and we do see an increase in that. In terms of projections and meeting those specifically, we keep having to reforecast them and make them higher. So it is kind of a moving target, but we do see an increase overall. And what I do anticipate is us getting very close to utilizing the overall projected amount with this $6 million.
So you see you're using it, but have you to this date used it? Now we've upped it, but has it been utilized fully each year to your knowledge?
I don't know, to my knowledge. I think that, again, it's somewhat difficult when we've had so many waiver amendments and so many changes to the programs over the last 3 years. With the new waiver cycle, we've amended, just with the own waiver I administrate, we've amended that waiver 5 times in my 1.5 years here. So we redo the projections every time, so it is a little bit of a moving target. I do think that we've gotten very close. I don't know in full if we've hit every single projection.
Okay, all right.
Thank you, Mr. President. I was going to add, while we probably can't answer whether or not we've used the full amount, there have been what I call structural impediments to accessing the benefit, both in terms of the single entry points having the knowledge to do it, having available contractors. So we're coming in conservatively at the $2,500 because we anticipate with the changes we're going to make to the benefit, it's going to be easier to access the benefit. We're going to have more contractors, better quality, and so Right now we're saying 2,500, but if we do find that the utilization is lower, we may up that, and we may go back and say we need more funding. And I anticipate that because the recommendations coming out of the Community Living Advisory Group, there's a lot around housing, and we know that's one of the biggest issues for our clients, so I would anticipate this going up. But for now, just to be safe, we're doing the 2,500 knowing that we want to go higher in the future. But we have to make all the
Good.
pieces come together.
Right, understood. Sorry, Josh, didn't mean that.
I just had a couple additional comments on that. I think the moving whatever piece of this goes over to DOLA is going to be a big help. I didn't mean to make you spit up your water there, Suzanne. I think it's no secret that there's been some issues with this program. I know a lot of people who have $10,000 ramps, who have $10,000 showers, who have $10,000 kitchen remodels. No matter what was needed, it was $10,000 conveniently, because the contractors who have been approved for this program know that there's a cap. They know what the cap is, so whatever they do goes to that cap. So I think that there will be a savings seen in future years. And I just want to point out, $2,500 literally won't probably do anything for a lot of people. I mean, it might get you a wider door on an interior door. It's not probably going to get you a shower. It's maybe going to take out some cabinets under a sink if you're lucky enough to have the clearance. So I don't know that there's going to be a lot of people who have already maxed out that $10,000 that this $2,500 will really do much for. And if somebody is in the hospital waiting for a home mod and they're waiting 2, 3, 4 days, that's going to cost a whole lot more than $2,500. So I think looking at the bigger picture savings on getting home mods done right, done quickly, is an important component of this. It's going to be, it's numbers that are going to be really difficult to really come up with black and white numbers, but I think there are additional savings from administering the program appropriately.
Thanks, Josh. So I just want to take a minute because I think that he highlights some really big concerns that we all have, certainly the department shares in regards to the home modification program. And that's that kind of immediately, let's just put something through on the PAR that says $10,000. What we're not qualified to do at the department is really understand contracting. I mean, like I said, I can swing a hammer, but I don't know if you'd want me to go, redo your shower or your door or anything. I do it on my own home and gotten hurt several times, so there's that. What we do know is that there's lack of quality control in this, but one of the things that is super kind of easy off the bat to implement is that we can take, with DOLA's knowledge, we can basically take the process and put some safeguards on the front end and the back end. And one of those front end safeguards is whatever the bids are, there has to be a full understanding on the client. They need to sign off on that. DOLA makes sure that the bid is appropriate to the actual work that's being done, and then that goes through on the PARing process. And so we know that putting extra steps into a process that sometimes can already take a long time is somewhat concerning, but that's where the case management training comes in. That's where the work we've been doing with DOLA comes in. And what we anticipate is that being a very quick turnaround time, they'll have someone dedicated to make sure that the work that's being proposed is tied to the actual amounts that are on the proposal, and the client has to be giving those the okay before someone comes out and starts excavating their yard. We also know that the $2,500 within the context of a $10,000 lifetime benefit may not be the exact amount that many people will need. What we know with this slight rule change in getting people the money, though, is that I've gone and visited some home modifications, and I've seen the work that has been done versus the work that was done 5 years ago. I think there's been improvements slowly but steadily. We want to make sure those continue to happen, but we also want to make sure, and this is why we put the clarification in the rule, that if someone has had a home modification done 5-10 years ago, that they can go out and have a contractor come and fix the ramp again if boards are starting to crack, if issues is going on with the sidewalk. I know that's oftentimes what happens here in Colorado. And so we know that and recognize the fact that $2,500 isn't the ideal amount for people to really increase their lifetime limit to have this benefit do wonders for them. But we do know that this is a really important first step to make sure that people can still remain independent in their community and access more additional money for repairs and whatever else they need.
Thank you. Other questions from the board? Mr. Winkler, any comments?
I just one final note. I bought a house 2 years ago, and I didn't use this benefit because of not even just rumor and hearsay. I mean, pictures and evidence in people's houses I've been to that I would have had to rip out a lot of the work to have it redone. And the clients have not had a lot of influence. You get 3 bids, and the lowest bid wins. And so you might want one thing, but the contractor bids something lower, and that's what you get. And it might not be what you like. It might not be really what you need. And so I think I applaud the department for working on this. It's been a long conversation. I think it's still going to be a long conversation to get it fixed and right. But this is definitely a big first step.
I appreciate your comments, and I hope you're part of the stakeholders.
Definitely will be.
This, I understand the need to take a kind of a baby step with the $2,500 now, but I look forward to hearing this in the spring. I think it's a very important rule to allow people to stay in their homes, and the dollars spent up front there are definitely saved on the backside. So we look forward to that rule coming back.
Great.
Anyone else would like to sign up for public testimony? Thank you, Mr. Winkler.
Doug doesn't want to leave.
Seeing none.
But I'm comfortable.
Yeah.
It's nice down there.
We have a motion and a second. Yes.
I believe, hi, this is Brigida Hughes. Colin, I just think there's a simple typo on line 26 on page 1 of 5. Is that supply dash, or is that anything, if that really needs to be there?
On line 26 of the first page of the rule.
Yes. Installing specialized equipment and plumbing systems, equipment and SU dash.
I think what that was, that there was a space there.
Yeah. No, that's a fix. That was one of the when I got the rule, there was, you see those kind of random issues. So.
New language, supply.
Yeah. An emphasis on supplies. Sorry.
So we have a motion and a second for initial approval of document 7. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Yeah, absolutely.
Aye. Great, we've got initial approval of document 7.
Thank you.
Move on to document 8. Could I have a motion?
I move the initial approval of document 8, MSB 14-07-15A, revision to the medical assistance community living benefits rule concerning consumer-directed attendance support services 10, CCR 2505-10, section 8.510, incorporating the statement and basis and purpose and specific statutory authority contained in the records.
Second.
Got a motion and a second for document 8, and we have Candy Dalton here presenting.
Good morning, Mr. President, members of the board. My name is Candy Dalton, and I am the Participant-Directed Program Specialist, and I'm here with Kelly Jepson, who is the FMS Contract Manager and will be presenting this rule.
Good morning, Mr. President, members of the board. Can everyone hear me okay in this? Okay.
Keep it close.
Yeah.
Keep it close, okay. My name is Kelly Jepson. I'm managing the FMS contracts, which stands for Financial Management Services. So this rule revision is basically reflective of a lot of stakeholder input to offer our Medicaid clients, our CDOS clients specifically, more choice in choosing an FMS agency. So I'll give a brief overview of CDOS just to make sure everyone is on the same page, and then I'll talk about the FMS changes to the rule. CDOS stands for Consumer Directed Attendance Support Services. It's a consumer-directed service delivery option within our HCBS Medicaid waivers. Within that service delivery option, CDOS clients can hire, train, manage, fire attendants who provide the care. Attendants within CDOS can provide personal care services, health maintenance services, and homemaker services. And so the FMS component of that, the financial management services component, is basically the agency that the department contracts with to manage and process the payroll for CDOS attendants. So the rule change today is basically to reflect CDOS clients' desire for additional choice in FMS agencies. Currently, the department operates with one FMS agency. You all may know them as PPL, Public Partnerships. Because of a lot of stakeholder input, the department has decided to move forward with contracting with 3 FMS agencies so that CDOS clients can choose one FMS or another. These changes will go into effect on January 1, 2015, so the department is proposing a rule change to sort of reflect those stakeholder-driven changes for more choice. So the main changes that we've made in the rule, basically, the rule as it was written only allows for one FMS agency, so we had to make some basic changes in the rule to allow us to operate with additional FMS agencies. And then we also are going to offer clients moving forward the option of 2 employer models. So I'll give a little background on that. So currently, the FMS agency in Colorado operates with one employer model that's known as Agency with Choice. In that model, the client and the FMS serve as co-employers and share employer responsibility for the CDOS attendant. So moving forward, the department will also offer the fiscal employer agent model. So the fiscal employer agent model enables the client to take on additional employer responsibility and have a more direct employer-employee relationship between the client and the attendant. And if you all have any questions about those employer models, we know that they're kind of confusing and there's some subtle nuances there, so just please let us know. So those are the main differences. So we've changed the rules to allow for the 3 FMS agencies and then allow for the additional employer models. We've made some other minor changes, namely with the rhetoric surrounding long-term care. We changed long-term care to long-term services and supports. And we have some minor feedback that we received from the AG's office. We received that memo yesterday. One of them had to do with referencing the Affordable Care Act in the rule. They felt that we didn't need to do that because the FMS agencies are responsible for complying with that regardless of whether or not it's in the department's rule. And then as well as I think just a minor citation issue, and we'll be addressing those before we come back for a second reading. Did I miss anything?
The only thing I want to add, the only thing I want to add is the third major change. Our current financial management services agency, Public Partnerships, provides the financial management services, so support with payroll and attendance support, as well as consumer-directed training to clients and authorized representatives. So there it goes. Moving forward after January 1st, we will contract with a 4th entity that will provide the training to CDOS clients and authorized representatives. So we're removing that role from the financial management services, so they're very distinct. That training and operations vendor will also provide ongoing and regular training to case management agencies on consumer direction, not just our consumer-directed attendance support services, but also our in-home support services. And as the department moves forward with other consumer-directed options, this training and operations vendor will provide that kind of support and technical assistance.
Questions from the board on this rule? Anybody on the phone with a question? The one thing that I'd like to, just a simple thing to point out too, is since you added at the very beginning of the rule that line 5 through 7, now you use the initials FMS without defining what it is, which is the paragraph below, so we could just kind of move that up so it's clear.
Absolutely.
All right, we do have, Ms. Redden?
Well, whenever you want to say.
You can say something now.
Okay, so I feel compelled to talk about this rule change and the change in the contracting. And I've talked before about how the department's, our vision is to align with the triple aim, which is to improve the client experience, improve the quality of services, and decrease costs. And this is, I think, a beautiful example of us achieving that.
Absolutely.
We're improving the client experience by giving them choice. We're going to improve the quality of services by, consumers can change vendors if they're not happy, so they can get the quality they want. And by procuring in the manner that we did, we actually are decreasing the cost of this contract from $9 million per year down to $3 million per year. So, I mean, you can't ask for more than that. Higher quality, customer choice, lower cost. So I am just thrilled with how this has all occurred and where we are today in terms of CDOS and the consumer choice.
Thank you. We do have Josh Winkler signed up for public testimony on document 8. Come up and
Well, he's coming to the table, Christy Blakely. I just want to tell you all how I can't say enough good about this program. I have a daughter that's on CDAS, and it makes all the difference in the world for her ability to be independent, and so thank you.
thank you. Mr. Winkler?
And once again, I'm Josh Winkler, and on this one, I actually represent CCDC. And I just want to, first, thank the department for this. This has been a long discussion at the PDPPC, Participant Directed Program Policy Committee? Collaborative. Oh, I was so close. Which is the stakeholder group who works on the CDOS and IHSS issues. And it came up for several reasons. I mean, a lot of people have felt unhappy with the present vendor for various reasons. And the other ones might be just as bad, you don't know. But if you don't have a choice, you don't know that. And CDOS has always been all about choice, so this really does open up the choice. There are two federal issues that also are helped by this rule. One of them is the Affordable Care Act and the employer mandate. And there was a lot of discussion around that at PDPPC roughly a year ago on whether or not PPL would be responsible for providing health insurance options for the employees. And that the two employer models play in very big on that. One employer model would require them, if they have enough employees and the employees are working enough hours, that they would have to provide the health insurance. The other employer model would not. The second federal rule is something known as the companionship exemption that has been around for, I think, about 100 years. It's been around a while with the Department of Labor, and it, amongst other entities, home health care aides and workers were exempt from overtime rules. So if an employee worked over 40 hours, you didn't have to pay them time and a half. And the Department of Labor, as of January 1st, has repealed that companionship exemption. Just this week, they did agree to delay the enforcement of that policy until July 1st of next year. And from July 1st till December 31st next year, it'll be on a case-by-case basis. As long as states are trying to figure out how to address it, they won't enforce it still, which I would not want to be the state having to argue that discussion. And so where this really plays in on CDOS, the best way to explain this by example. If I am a CDOS client, and if I have an attendant who also works for Christy's daughter, let's say, and between the two of us is working 45 hours a week, who pays that overtime? Does it come out of my allocation? Does it come out of Lauren's allocation? If normally they only work 38 hours and we both are maxing out our allocations, and one of us has a problem and needs a couple extra hours, but the other one is the last one to submit their billing in, are they the one who gets stuck with that overtime, even though it was my fault that I went, that they had more hours? The companionship that companionship exemption also addresses mileage, which we have no control of where our attendant is coming from, but we're going to be responsible for that mileage. And so it's complicated stuff we need to work through. And one way that we can deal with that on CDOS now will be, I go with a different FMS, or I go with a different employer model, and we just solve that problem. Doesn't help the aide get overtime. It doesn't help that aide get paid. And it comes across as a message sometimes that we don't support attendants being paid well or getting that overtime, and that is not it at all. It's just that there's no funding mechanism for that overtime. And so this will at least allow us some options so we don't run out of our allocations. So the state has a little more time to help figure it out on longer term how we're going to do this. And a little more background, the state actually has that currently in law. The overtime requirement's already here in Colorado. They've been here for 3 or 4 years. They've never been enforced because nobody knows how to actually make that work. The feds aren't going to pick up the extra overtime. The state, it doesn't have in their budget to pick up that extra overtime. So this change will definitely help both of those, both the ACA issue and the Department of Labor issue, as well as give clients the choice that they've wanted for a long time. And I do want to mention that the 3 entities that got the FMS I think are very interesting. It's the existing public partnerships, which does this in a lot of states already. It's the Northeastern Center for Independence out of Pennsylvania, and the third was a financial. Morningstar Financial Services. So I think it's 3 very different entities that got the contract, which should give people, the people who run those organizations, obviously are going to have 3 different mindsets, so you might get very different quality of service out of the 3. And I think it's going to be very interesting to see how it plays out.
Are those contracts annual contracts, or how do the contracts work in the state?
So the initial contract period is from the effective start date to the operational start date. The operational start date is January 1 of 2015 through June 30th of 2015, and then we have the option to renew for an additional 4 years following.
Any other questions from the board? Is there anybody else who would like to sign up for public testimony? Thank you, Mr. Winkler.
This is Tim Fox. I just wanted to make sure that I was hearing. It was really difficult to hear Mr. Winkler. Ultimately, Mr. Winkler was in favor of this. Is that my understanding?
Right, he's shaking his head yes. Yes.
Thank you. Sorry, it's just hard to hear on this end.
Yeah. All right. Anything else on the rule that you want to present?
This is Candy Dalton. The only thing I'd like to add, and I thank Josh for his comments regarding the Fair Labor Standards Act companionship exemption and the requirement of overtime, because the Federal Department of Labor has narrowed the definition of that companionship exemption. So while moving forward with these different models and different FMS agencies will kind of help mitigate that, we do have a lot of work to do to still work with stakeholders and figure out how to go forward once the Department of Labor starts enforcing that. And so we are working on that.
All righty. Well, we have an initial motion and a second for initial approval for document 8. All those in favor signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Great. We have initial approval of document 8. Thank you very much.
Thank you.
Moving on to document 9, if I could have initial approval motion.
I move that the initial approval of document 9, MSB 14-07-28-D, revision to the medical assistant client and clinical care durable medical equipment rule concerning complex rehabilitation technology, section 8.590, incorporating the statement of basis and the purpose and the specific statutory authority contained in the records.
Second.
Motion and second for document 9, and we have Escadar McConan.
Yes.
Welcome.
Okay. Good morning, Mr. President and members of the board. My name is Escadar McConan. I'm the RX Review Program Coordinator for the department, and I have with me Tom Leahy.
Good morning. My name is Tom Leahy. I'm the Pharmacy Policy Supervisor.
And we're here to present on document number 9, MSB 14-07-28-D, revision to the medical assistant client and clinical care durable medical equipment rule concerning complex rehabilitation technology, section 8.590. This rule change is part of the implementation of the Complex Rehabilitation Technology House Bill 14-1211. And this bill requires the department to recognize complex rehabilitation technology as a unique category of service under the Medicaid program. Complex rehabilitation technology from here on, which I'll refer as CRT, is individually configured manual and power wheelchair system, adaptive sitting systems, alternative positioning systems, standing frames, gait trainers, and specially designated options and accessories which qualify as a durable medical equipment. And all these devices are already current benefits administered as a durable medical equipment. They're just not labeled as a CRT. And all the changes that you see in this rule come straight from the CRT bill. So to walk you through the changes that we have made, if you turn to, or scroll down to page 1 of 17 on the rule document, there are definitions we've added, and from line 8 until line 23, there's a definition of what CRT means, and this language comes straight from the CRT bill. And if you look a little further down, on line 24, there's a definition of what CRT professional means. These are individuals who are certified and are experts in CRT devices, and they are hired by the CRT supplier, and they're part of the process of assessing and determining the right CRT for clients. And on line 28, there is a definition of what CRT supplier means, and these are providers who meet all the new CRT standards, which we will be talking about in an upcoming section pretty shortly. And if you can go to page 2 of 17, there's a definition of financial relationship from line 1 to line 6. And the CRT bill requires there be no financial relationship between CRT suppliers and qualified healthcare professionals such as physical therapists and occupational therapists who will be performing the specialty evaluations for the clients. And this definition makes the scope of financial relationship clear. And also a little further down on line 14, there's a definition of immediate family member. This is a phrase used in the financial relationship definition, and it's just further defined to make it clear and to show what is really considered immediate family member. And the last definition that we have added is on line 27 through line 30, and this is for what qualified healthcare professional means. And these are licensed physical therapists, occupational therapists, and other qualified healthcare professionals within their scope of work who will be performing specialty evaluations for CRT clients. And as part of complying with the bill, the department is adopting CRT supplier standards. And if you can go to page 13 of 17, and starting on line 17, that's where the supplier requirement or standards are at. So to qualify as a CRT supplier, a provider has to meet these qualifications. And the first one is they have to be accredited by a recognized organization as a CRT supplier. They'll have to meet Medicare and Medicaid's durable medical equipment supplier standards. They would have to employ at least one CRT professional at each physical location of service. And this continues on to page 14 of 17. And there are some quality standards that they would have to maintain, such as having a reasonable supply of parts, adequate physical facilities, and qualified and adequate service or repair technicians to make sure prompt services to clients are done. And the last one is they would have to provide clients with written information at the time of sale on how to access service and repair for the CRT they are supplying. And lastly, as part of complying with the bill as well, the department is restricting the reimbursement of CRT to only qualifying CRT suppliers. And if you can go to page 17, so the last page, starting on line 16, that's where we lay that down. And in this section, we communicate that for reimbursement of CRT, there are some conditions that have to be met. And the first one is the billing provider has to be a CRT supplier. Second, the clients have to be evaluated or assessed for CRTs identified, which will be identified in the medical bulletin by both qualified healthcare professionals and CRT professionals who are employed by the billing provider. And lastly, the CRT provider has to be in compliance with all the rest of the federal and state rules and regulations that governs the medical assistant program. So, in summary, this rule change recognizes CRT as a unique category of service under the durable medical equipment. It adopts new CRT supplier standards to ensure that the department is in compliance with the state statute.
Ms. Roberts?
Thank you, Mr. President. This is Donna Roberts. I was questioning, I love the fact that you do the CRT standards. I think it's essential because it is, it has some ramifications if not done correctly, and thank you for doing that. My questions are, however, on page 11 of 17, lines 10 through 15, and on page 12 of 17, 22 to 45, it talks about that the provider is responsible for making adjustments and evaluations, etc. Are there periodic assessments to be done, and should that be in statute so that it mitigates problems with pressure areas, diffuse, atrophy, contractures, etc.? Because if it's kind of one fit, unless something breaks over the period of 4 or 5 years, there could be unintended consequences that would be devastating.
Yeah. Thank you so much for that comment, Ms. Roberts. So we are currently working at the Wheelchair Benefit Collaborative meetings to specify when specialty evaluations should be done. And these are one of the things that we are looking into. Even though there are some requirements for example, when you are getting a new CRT or at the end of the 5 year, or when you have when the client has had quite huge medical condition changes, we are leaving it also on as needed basis, and so that if there is any type of reason where the client needs to have these evaluations done, then they would have the option to do so.
Okay, thank you very much.
Other questions? One that I had, and one I'd never heard of CRT before, and you did a very nice job of defining it and laying it out there. I thought that was very well done. As you talk about CRT qualified providers, just for my own information, are there a number of qualified providers throughout the state, or is it a limited pool, or?
So, we've looked into how many providers currently do supply these type of devices. Like I mentioned earlier, we do currently cover this benefit. It's just not labeled as a CRT, and there are quite few, maybe I would say, about 10 providers around the state who would qualify as a CRT supplier if they wish to continue.
Okay, are they geographically dispersed, do you know, or is it front range?
I would, at the top of my head, I wouldn't be able to answer that to you, but I can look into that.
That would just be the kind of concern that if we're going to start limiting people across the state that they have to come to Denver for these services, maybe that's where they have to come now. I'm not aware of.
Okay.
Mr. President, this is Pat Gibbons. I
Yes.
have the same concern and question about the geographic location and access for patients, and somewhat related to Donna's comments and the unintended consequences of, skin breakdown, other issues.
So that would be
Will
great.
we track also the outcome of this change?
Definitely, and this is one of the things that we're also discussing at the Wheelchair Benefit Collaborative. The access issue has been brought up, and we are looking at different possible solutions to address access issues for clients who live in rural areas. And this is an ongoing conversation that we've been having.
This is Christy. I can just make a comment that Colorado's come a long way in having qualified providers and experts in seating. Prior to these days, we went as far as California to get our seating needs met. So we've come a long way, and I'm really pleased to see this and have been involved in the Wheelchair Seating Collaborative. So just kudos.
That's great. That's great. I just want to make sure this rule doesn't, with the unintended consequence, limit people who are currently doing this in other areas, or what it takes to be qualified.
Yeah, but it's hard because they need to have enough product to show and demonstrate, seating cushions and all of those kinds of things. So often you're seeing those in universities and established institutions. So there are folks that do travel as well for those seating evals.
Thanks. Other questions from the board? We have Mr. Winkler signed up for public testimony on document 9. We haven't seen you for a long time, and you're making up for it. That's great.
The poor dog is saying, why couldn't you just leave me up there?
Welcome, Mr. Winkler. If you could let us know who you're representing in this testimony.
Keystone, sit. I'll get my dog to lay down and never get up. I'm going to pull this a little closer, so maybe. Thanks. So I am Josh Winkler again, and I normally wouldn't be up here this much, but there's just so many good rules this week or this month. So I'm Josh Winkler, and I'm going to represent CCDC on this one again. And we were a big part of the discussions on this legislation originally. And I just want to give a little bit of background on kind of why this legislation came to be. It was provider driven, but also in collaboration with the department and clients. Because there's a lot of issues at the federal level, and I feel weird like dissing the feds here again and again today, on the Medicare side. Medicare has a very poor DME benefit to begin with, and then they've created this competitive bidding process for how you get your equipment. And so they get people who win the bid, and that's who your provider is. And you might be in Colorado, and the closest vendor is in Florida. Evidently, Florida has really poor laws around protections, so most of the companies tend to be based out of Florida. And so it's become more and more difficult on the Medicare end to get any kind of DME that is decent, any kind of providers who can provide the service. And so that was kind of the reason behind the bill to begin with, and why to create this separate category to kind of help protect this benefit long term, even though it was already a benefit here in Colorado, just to give it a little bit of additional protections. And I do want to answer your question about the providers, the number of providers. It does become a problem. It is an issue at times in Colorado. There's one main company and then a handful of others. New Motion, it used to be ATG, merged with United Seating and Mobility on the national scene, and they are now by far the largest provider in the state, in the country. I believe they're in like 32 states. And so you have a choice of New Motion, who has, as Christy mentioned, has the inventory, has chairs to look at, sizes to try, seating systems to try, has the spare parts. Or you have, the local shops who aren't able to do that as well. They try, and oftentimes they try harder on the customer service end. And so you have a choice back and forth of who you use. And I don't know that this bill helps or hurts that. There's a multitude of reasons why that's happened over the years, why they've been able to buy out everybody else. And they have bought out a lot of the small companies. That's how they became the powerhouse in the state. But they also have a fleet of vans and techs who travel throughout the state and provide the services, and that wasn't available as well before they did that. So there's wins and losses as one company takes over the majority of the services. And I do want to give kudos to the Wheelchair Benefits Collaborative, because I participated in several benefits collaboratives that didn't feel very collaborative, and that particular one has been a very good process from the beginning. There's various providers, both on the DME providers and the PTs and the OTs, and clients, all involved and all having very good discussions about some of these difficult issues on how to get the best balance for everybody. And I do think that this rule's just around the DME bill last session, but the forthcoming rules coming out of the Benefits Collaborative, I think, will address a lot of these other issues around DME and help tighten up the benefit for everybody.
My assumption is you're in support of this?
Yeah, definitely in support. Yeah, thanks.
Questions on the phone? I don't have anyone else signed up for public testimony. Would anybody like to testify for document 9? Otherwise, we do have a motion and a second for initial approval of document 9. All those in favor, signify by saying aye.
Aye.
Aye. Dr. Young?
Aye.
Dr. Givens?
Aye.
Mr. Fox? initial approval of document 9. Thank you very much.
Thank you.
2 more to go. Let's have a motion for document 10.
Move the initial approval of document 10, MSB 14-09-03-A, revision to the medical assistance eligibility rule concerning 5%, income disregard, section 8.100.4.d, incorporating the statement of basis and purpose and specific statutory authority contained in the record.
Second.
Got a motion and a second for document 10, and we have Anna Rodallo.
Yes. Good morning, Mr. President and board members. Thank you for your time. My name is Ana Bordallo. I'm the CHIP. Let me just pick this up a little. I am the CHIP. I am the Child Health Plan Plus policy specialist. I am here today to present the rule concerning the 5% income disregard for both Medicaid and Child Health Plan Plus. 5% income disregard is automatically applied to our modified adjusted gross income MAGI populations for the purposes of determining eligibility for Medicaid and CHIP. In 2013, the Centers for Medicare and Medicaid Services revised the federal rules regarding the applicability of the 5% income disregard. And allowed states to schedule systems and business process updates no later than January 1st, 2015. The revised federal rules require states to amend the disregard for the purpose of determining eligibility for individuals whose MAGI-based income is above the highest applicable income standard under the program Medicaid or CHIP. The 5% income disregard will only be applied when countable income exceeds the federal poverty level for MAGI populations under Medicaid or CHIP. The 5% income disregard will not be applied to every MAGI eligibility determination. It will be applied as a last step in determining eligibility when an individual exceeds the income standard. Implementation of this rule is necessary in order to be in compliance with the federal regulations. The rule will benefit individuals for whom the disregard matters for determination of eligibility, in which the application of the 5% disregard means the difference between being eligible and ineligible for Medicaid or CHIP. The proposed rule will impact MAGI populations under Medicaid or CHIP with the highest income standard identified as the following categories. The MAGI adult program under Medicaid, the Medicaid and CHIP program for children, and the Medicaid and CHIP prenatal program for prenatal women. The department has initiated steps to incorporate this policy change into a project plan and will implement changes effective January 1st, 2015. We also created a frequently asked questions document to help address the policy change for this. Are there any questions? Mm-hmm.
And so this really clarifies it, and I'm glad that you're putting together a FAQ to
Yes.
get the word out for people to understand.
And it will be posted to our website. So.
Great. Thanks. Ms. Riley?
Yes, this is Ginny Riley, and I think that especially using common sense in what we do and not adding workload is always important, and it doesn't make a bit of sense to apply the disregard when people are way below
Correct.
the maximum income. It's just an unnecessary task, and I think it's a good thing to eliminate that.
Thank you.
Questions from anybody on the phone? We have nobody signed up for public testimony. Would anybody like to sign up for public testimony on document 10? Seeing none, so we have a motion and a second for initial approval of document 10. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good, we have initial approval of document 10. Thank you very much.
Thank you.
Our last rule of the day then is document 11. We have a motion.
I'd like to move the initial approval of document 11, MSB 14-06-19-A, revision to the medical assistance eligibility rule concerning long-term care institution recipient income calculation of patient payment increase to the personal needs allowance, or PNA, for residents of nursing facilities or intermediate care facilities for individuals with intellectual disabilities, in parentheses ICF-2D, parentheses, section 8.100.7.v.3, undercase D, and 8.100.7. Lowercase f, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Woohoo!
Wow. I think I picked the longest one. Yeah.
Second.
We got a motion and a second on document 11, and we have Eric Stricka.
Stricka, yes. Good morning, Mr. President and members of the board. I'm here to present that rule. It's very specific. So really all it is increasing the personal needs allowance that's been set in place for a number of years. It's been set at $50 for inpatient nursing facility and the residents for intellectual disabilities. So it goes to $75 starting on January 1st, and simultaneously there's an increase to that. So there will actually never be a $75 personal needs allowance. It'll be more than that upon the implementation. And it also sets in place a yearly adjustment to that personal needs allowance. So each year it sets a new base amount, and that base amount is adjusted by the average per diem rate for all nursing facilities statewide. So it won't be stuck in place for a number of years, and it'll allow an increase in those personal needs. Any questions?
There's some written testimony that we received from a Patricia Cook who had concerns of that this doesn't match up with the assisted living amount.
Yes, and the rule is to implement the Senate bill, which changed the law for this, and it's specific to medical facilities. So assisted living facilities are considered community placement, and there's a separate set of rules that surround what personal needs are in those settings. So we'll take this under advisement and kind of take a look, but it doesn't, the Senate bill doesn't allow us to make any changes to those personal needs allowances.
Other questions from the board? I'm not sure if I understood you when you said that it's going to go up to $75, but nobody will get $75.
So right now it's $50, and the bill actually took place, or it allowed it to take place on July 1st, but because of getting system changes in place and state plan amendments in place, we needed to make it go effective January 1st. So even though we're not able to give that actual $75 until January 1st, but it will. So it'll be a 3%. It's usually a 3% adjustment to that per diem rate. So it'll be the $75 with an immediate 3% adjustment to that. So it'll be $75 plus the 3%.
Any questions from anybody on the phone? Nobody has signed up for public testimony on document 11. Would anybody like to sign up? Seeing none, we do have a motion and a second for initial approval of document 11. All those in favor, please say aye. Aye. Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good. We have initial approval of document 11. Thank you very much.
Thank you.
You made it through those 11 rules. Consent agenda as we look forward. I have down 4, 5, 6, 7, 9, 10, and 11. I'm not sure what everyone else is.
That's what I so moved.
Okay. We got a motion then to.
Second.
Motion and second to include documents 4, 5, 6, 7, 9, 10, and 11 on the consent agenda for next month. All those in favor, signify by saying aye.
Aye.
Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good. And now if I could have a closing motion, please.
Move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference.
Second.
Second?
All those in favor?
Aye.
Aye. Dr. Young?
Aye.
Dr. Gibbons?
Aye.
Mr. Fox?
Aye.
Very good. All right, thank you all very much for the rules portion of the agenda. We do have 2 people signed up for public testimony, so I. We could, I was just gonna say.
We need a break.
Okay.
Sorry. Hours.
I didn't do that.
We are not gonna take a 2-hour break. If we have a break till 11 o'clock, would that work okay for public testimony? Yeah? Okay. So let's go ahead and take a break until 11 o'clock. Thank you. If I overheard them right, they're all coming up together, is that true?
I saw the look.
So we have Josh Winkler, Julie Farrar, and Eric Stricka coming up for public testimony. So I guess we'll give you each 5 minutes.
No,
No?
not necessary.
Okay.
And
Welcome.
thank you, Mr. President and board members.
Pull your microphone.
Oh. Thank you, Mr. President and board members. And my name is Julie Farrar, and I am the policy analyst for the Colorado Developmental Disabilities Council, and I apologize for not identifying myself at the last meeting when I was pretending to be Josh Winkler. But we're here to give an update today on the issues that we brought forward around income assets and asset recovery, actually.
And once again, I'm Josh Winkler, and I'll represent myself on this one for now. And we brought Eric Strick in because we've had some conversations since the last MSB meeting with the department on this to try seeing what we can do. And I just want to back up a little bit to give a little clear understanding of what the issue is. We kind of hijacked the rule last time on asset recovery for people who are newly eligible through the Affordable Care Act. That group of people already didn't have an asset limit, and now they aren't subject to asset recovery unless they get long-term services and supports. The federal government does require anyone, regardless of eligibility category, who gets long-term services and supports, that the state at least try to recover assets upon their death. And so people with disabilities, younger people with disabilities who are trying to build a life and acquire, one of the things you want to do is you work and you get a house. Right now you're allowed 1 house, 1 car, and up to $2,000 in assets. That is the limit, and that's based off of the Social Security, the SSI rules on asset limits. But that's been carried over into other categories that are not federally required to have an asset limit. One of the main ones is a 300% of SSI eligibility category. And so it becomes an issue as we have more and more younger people. We're trying to encourage work. We have the Medicaid buy-in program. There's other federal programs to help encourage employment. But there's still no real programs to encourage the gaining of assets. The Medicaid buy-in program does allow for somebody to have in excess of $2,000. There is no asset limit. However, if you lose your job or you turn 65, both of which happen to most people in life, on the first of the following month, you go into a different eligibility category to remain eligible unless you get a new job or you go under 65 somehow. And the asset limit applies again. So if you've been saving money to buy a car, put a down payment on a house, put your kids through college, the first of the month following job loss or turning 65, you're now subject to that $2,000 asset limit again. So you have to liquidate all your assets, get a trust, do something in that month. And so there's no, it's a huge disincentive to real employment still. And so we've been looking into ways that we might be able to address this. Over the last several months, I've had some conversations with Curtis Valesky over at Region 8 CMS, and it appears there is a way, at least for some eligibility categories, that the asset limit could either be raised or eliminated. The pushback is going to come because people who, traditionally the reason it's been there is when people go into a nursing facility, the common practice is you burn through all your personal assets before you become Medicaid eligible. And so people have to liquidate assets and it happens in a few ways. People liquidate their assets ahead of time because they know it's going to happen. So the kids get the inheritance in advance. So when mom gets old enough, she can go to the nursing home and get Medicaid. Or they form a trust and they find a way to shelter their assets. Or they just end up in a nursing home and the nursing home gets paid from their private assets until they're broke and in poverty, and then they get on Medicaid. If things worked as they should, in my opinion, the estate recovery takes care of that. What I'm proposing is if we eliminate the asset limit, allow people to accrue assets, upon their death, the state's required to go after their assets anyway. If that asset recovery actually works, then they should get the money on the back end anyway. So you don't force people into poverty to get them on Medicaid. You allow them to get on Medicaid, and then at the time they die, you get the money on the back end. And for the younger people that likely would never accrue assets, now we would have the opportunity over our lifetime to actually accrue assets and be worth something when we die. The asset recovery program doesn't get hardly anything in comparison to the overall Medicaid budget right now. And I think that is in large part because people know, one, people liquidate assets in advance, so the nursing home doesn't get it. I mean, it's not like that's a big secret. People who have the wealth to do it, get trusts, find ways to shelter their money, give it all to one spouse, give it to a kid, and really still have access to that money. And so we've created all these schemes to get people Medicaid eligible through poverty, because that is the way, if you're going to get long-term services and supports, you still have to live in poverty, other than the Medicaid buy-in program. And like I say, the Medicaid buy-in program created that, no asset limit, but again, the first of the month following the job loss or turn 65, it does apply. So it really isn't the incentive that it appears to be on paper. If you're lucky, you lose your job on the 1st. If you're not lucky, you lose your job on the 30th and have a day to liquidate your assets. So it's something that's going to take a lot of discussion. Obviously, fiscal modeling and stuff's going to happen. But if things work as they should, the state shouldn't lose money on it because they'd get the money on the back end upon our death. It would essentially mean that the state would bankroll the care on the nursing home end, which is where the pushback's going to come. That right now people have to burn through their assets, which might be a month or 3 months or 3 years of paying for their own care. And then Medicaid kicks in. But Medicaid kicks in if you live long enough anyway. You become broke enough that Medicaid will kick in. Instead, they would be able to keep those assets until they die, and then the state would get that money anyway. And they might spend a little of it, but they're not going to, if they have, hundreds of thousands of dollars or tens of thousands of dollars in the bank, they probably aren't going to. And I would argue that on the long end, the younger folks with disabilities who could work and accrue assets should make up for what's lost on the elderly population that currently pays in for a number of months. I don't know if Eric can give any updates as far as what the department's looking at.
This is Eric Strika, and again, I'm long-term services and supports, or long-term care eligibility policy specialist, more specifically financial eligibility. So that's why I'm working with Josh and Julie to kind of evaluate what are the opportunities under current law, federal and state, to work with the asset limits and things like that. So I don't have any further updates, but we just met and we're looking forward to
It'll be a long process, no doubt. Thanks.
Thank you very much for your interest in this.
Thank you for your time.
I don't have anyone else signed up for public testimony. Would anyone else like to sign up for public testimony at this time? All right, then, I think it's time for us to kind of move into our department updates. We received several of the stuff electronically. The House Bill 1293 update we received electronically. The Behavioral Health Organization Rural Advocacy Report we also have received electronically. And then in front of us here, we have the hard copy of the 2013 Department Annual Report. And so I'm not sure if the board has had a chance to review those or have any questions for the department at this time, but you do have those to make sure to keep up to speed on what's happening with the department. Questions from anyone on those three areas? Before we jump into the other department updates, I guess one of the big department updates is Suzanne's change, that she is going to be resigning from the department in a month or two down the road. Is that right?
December 1st will be the last day.
And I believe this is your last MSB meeting then? Did I hear that? Or
No, I
we're
have
going to see
one
you
more.
next
You'll get
month?
to see me next month.
Wonderful. Very good. You have any words of wisdom for us or what you want to say?
I absolutely have lots of words of wisdom. And I guess I would just say that I have enjoyed serving on the board as the department representative. And what's really gratifying is to see our work come to fruition here at the board. You know, you could view the role of the board as somewhat administrative, but really it is where the rubber meets the road in terms of making significant policy changes. So I have really valued my time here. And even today it was gratifying to see the home mod rule come back. That's been one of my personal favorite things that I've asked staff to really work on improving. When I got here 3.5 years ago, I remember meeting with Mark Simon, and he gave me an earful about home mod and how broken it was. And my husband's actually in construction, and I couldn't stand the fact that our clients weren't getting good quality and every bid was coming in at $10,000. So to see that we're going to be working with DOLA and making that benefit really work is very gratifying to me. And then seeing adult dental come through, also a big success that makes me very happy for the department. As well as I had something else written down here, let me see. Oh, and then CDOS. When I first came to the department, CDOS was a program that was very much under fire and a lot of questions about it. And 3.5 years later, we're in a very different place in terms of our approach to person-centeredness and the idea that our clients should be able to direct their services. So all in all, like I feel very good about what I've been able to participate in with our staff and all of our stakeholders across the community. So it is very bittersweet, but it's sort of a personal choice, personal goals, lifestyle. So Medicaid is all-consuming. It's also very addictive, and I just have to make sure a little bit of me left for my husband and everyone else. So, but I will be sad to not see you. But we can talk more next month.
We have one more month, that's good. Very good. So the next thing then is the pediatric assessment tool update, and we do have Matt Calusi here. We're gonna make you talk, you can come up by yourself this time.
Yes, sir, you've got me this time. Good morning, Mr. President, members of the board. My name is Matt Calusi. I am the supervisor for the Specialty Chronic and Hospital Unit with the department. And I am here to give you an update on the pediatric assessment tool. I have handouts here that you folks have in front of you. These handouts show the pediatric assessment tool in its first version, which was the calendar year 2013. And the second version, where we had updated calendar year 2014. Now the data tells us here the full amount of the prior authorization requests that went to our utilization management vendor, which is APS, which is the request from the provider that goes to APS to say that the provider says we need this specified amount of hours for this client. In this case, this shows the number of PARs that were submitted to APS, the amount that were approved fully, and the amount that were partially approved, which means that there was either a reduction or increase, typically a reduction in hours where the supporting documentation and the assessment tool itself did not show that the utilization management vendor, APS, felt that the number of hours that were being requested were appropriate for the client. On page 2 of the document, it will show in that first year of the pediatric assessment tool with version 1 that in 76.85% of those prior authorization requests that were submitted with the pediatric assessment tool, that 76% of those were approved as requested, and 22.95% were a reduction in hours. As we move to the second iteration of the tool in calendar year 2014, which is our current year, you'll see that 86.83% were approved as requested. The department feels that this is because the tool has been refined and that the tool has been refined, and we are seeing that providers are requesting the amount of hours they think appropriate, and the tool is reflecting that. In addition, there was a request over the summer from the board that we update you in terms of which diagnostic group received the most reduction in hours, and that would be autism spectrum disorder for those clients. And the data shows that in the majority of the cases, 15% of those reductions were for that particular diagnostic group. And again, the department has publicly messaged that we will be working on an autism benefit in the very near future here, so we recognize the need for that.
So I could just add on to that, CMS, if you might already know, has released new guidance around what Medicaid agencies need to cover in terms of autism. So that's what Matt was alluding to. We're going to process that CMS guidance in terms of what we should cover and how, and that will really drive the autism benefit that we come up with. The CMS guidance was somewhat vague in nature and left a lot open to interpretation. So that's why we can't just simply turn on a benefit that's directly related to autism. So I would also add that I think many of you were here for the home health work that we did over the past year and a half. That work is a good word for that. And so the history of that is that in the past, we were not reviewing home health requests for medical necessity. We were not doing any prior authorizations, and so there was an incredible amount of variability in what home health agencies were requesting and getting, and so that's why we created the pediatric assessment tool to improve the consistency of the evaluation and make sure there was consistency between home health agencies in terms of the hours we were providing. Another important thing to note is that home health is primarily for skilled services, and there was a lot of unskilled hours being provided under home health as well, and so we really needed to clean that up to be compliant with federal rules and regs. And so while we changed the home health rules and approach with the pediatric assessment tool, we've also been bringing up a personal assistance service so that children with autism can get the services they need, but just not necessarily under the home health umbrella. So I hope I explained that clearly enough. It's a lot, it was a long history, so.
And we're going to see that tool and that rule come next month. Personal care, November.
Great.
And I'm just wondering if that assessment tool be more behaviorally driven versus what we have now?
For personal care, for autism, we have not yet started working on that benefit. So, of course, as we move along there, we will definitely be updating the board.
Very good. Any other questions?
Thank
you very much.
Mr. President, members of the board, thank you.
Next, an update on Region 8 UPSDP program overview. Dr. Suzanne, you must be Gina Robinson.
I am Gina Robinson. Hopefully Dr. Zuzana's on the phone. I don't think she was going to be able to make it in person.
Yes, I am. Hello, everybody.
Yay!
Okay, thank you. Hold on one quick second.
This presentation is on your iPads.
Okay.
And it is the one titled "A Mandatory Service," is that correct?
Yes.
Okay, great. And if I can make sure you can speak into the microphone. All yours.
Thanks. So my name is Gina Robinson. I do work under Judy in the Client and Clinical Care Office. We always like to try to throw a program in there so we can be called C3PO, just we have a cool acronym. Judy hasn't gone for that yet, but we keep trying. So I was actually asked to come and provide a really quick overview of the EPSDT program, and that is the Early and Periodic Screening, Diagnosis, and Treatment Services program under Medicaid. Unfortunately, I am this thing standing between you and leaving or you and lunch. So I am going to take the 30 minutes and do it as quickly as I can. Please feel free to stop and ask questions along the way. Because I wanted this to be something that you guys can use and something that you guys can refer back to, I am going to use a federal presentation, not the Colorado presentation, even though I use a lot of their slides, because I didn't want this to be looked at as a department interpretation or Gina's interpretation of the program. So I am going to use the federal slides, which are the ones you have in front of you. You also have another slideshow in case you don't want to bounce back and forth. So I was very lucky enough to be able to meet with Lori Norris, Amy Hennessy, and Elliot Fishman, who's the CMCS medical director, earlier this week, and we came up with this presentation. Unfortunately, I do have orders to read some of their stuff, so I apologize for reading. I normally don't do that. So EPSDT, as I said, is the Early and Periodic Screening, Diagnostic, and Treatment Services Program, otherwise known as Children's Medicaid Benefits. EPSDT's goal is to serve the individual child to get the right care to the right child at the right time and the right setting. EPSDT is a mandatory preventative and comprehensive health benefit for most EPSDT Medicaid individuals under the age of 20. A good way to think about EPSDT is if a child or a youth can get into a bar, they can no longer get EPSDT services. So that's usually how I explain the break. It's really easy to remember. It was brought about in 1967 under the Social Security Act. It was modified in '69 to include outreach and case management. As my mother will tell you, she did not get any help from me. She was a single 18-year-old mother, and she lets me know it to this day because she didn't know about the program. So that's why outreach and case management was also added to EPSDT. It was also amended in 1989. No real additions, just real language changes. And really, honestly, if you go back and look at the federal regulations, they're all still redlined. None of them have been actually adopted, but we just take them as gospel anyway. EPSDT is about providing infants, children, and adolescents enrolled in Medicaid with early, so that's assessing and identifying problems early. Periodic, which is checking children's health at age-appropriate intervals. Screening, which is providing physical, mental, developmental, dental, hearing, vision, and other screening tests, including autism, lead screening. Diagnostic, which is performing diagnostic tests to follow up when the risks are identified. And treatment to control, correct, reduce health problems is found. There is a defined list of what EPSDT can cover. Sometimes we hear that the program is a blank checkbook or it's another way to get services out of Medicaid when Medicaid won't approve them. Section 1905A 4B is the list of actual services that are required to be provided. 1905R lists the mandatory services that states that must be supplied, as well as optional services. If you actually go look at that list, you will see that dental is listed as an optional service. I'm not sure that these days CMCS would say that dental is an optional service, but it is still listed as in the optional category. And 1905R defines EPSDT, and again, for children under 21. Examples under the screening are a comprehensive health and developmental history that assesses both physical and mental health, as well as for substance abuse disorders, anticipatory guidance that is intended to be an exchange between the medical practitioner and the parent or child about the current and next stage of development, and what to do or look out for to help the child or infant be healthy and safe, giving the healthcare professional, parents, and/or the child or adolescent a chance to ask questions and discuss issues of concern. We hear a lot about anticipatory guidance, especially these days around marijuana, gun control, those things. Anticipatory guidance is up to the provider. There's no clear guideline of what that should include. It's up to the provider depending on the area and the nature of the children that they see. Medical necessity must be determined on a case-by-case basis based on prior authorization, and prior authorization is allowed for services or items, but must not impede the delivery of the necessary services. A state cannot set arbitrary hard limitations on services, so we can't say 1 pair of eyeglasses or a limit of 10 physical therapy visits. Not everything a provider prescribes has to be provided. The state or its contractor makes the determination that it is medically necessary and coverable under Medicaid. So that goes back to that 1905A that we talked about just a minute ago. EPSDT does not require the coverage of experimental or investigational treatments, services, or items. Such services and items may, however, be covered at the state's discretion if it is determined that the treatment or item would be effective to address the child's condition. A really good example of that is orphan drugs. So orphan drugs could be considered to be experimental or investigational, but we have been covering some, such as Streptanol, for children in the state. A lot of them come here for the care given at Children's Hospital, and so that is an approved orphan drug. We are also required to inform all eligibles and their families about EPSDT services, including immunizations. A state must provide for that informing. We call it informing. We actually do that here through a program called Healthy Communities. And what we did is we took the EPSDT outreach that some of you may have known that was around for 30 years, combined it with the outreach from the CHP Plus program, and now we have one entity outreaching to all kids, because what we were finding is that when we went to do the inform, we could talk to the parent about one child but not the other, because one was on CHIP and one was on Medicaid. And it really didn't seem right, so we were doing it anyway. But we came up with a program that allows it to be done formally and has formal funding to it. States must also offer such items as transportation assistance, appointment scheduling assistance, and missed appointment follow-up. We do missed appointment follow-up at the provider request. So if the provider would like assistance with missed appointments in his practice, we hear it a lot, that providers don't want to take Medicaid because they're no-shows. And so we do offer the service through Healthy Communities, that if they would like to give those workers a list of who's missed appointments, they will go back and try to help them reschedule, work on transportation, see if they need, maybe go to another provider that has different hours. Maybe this provider doesn't accept Medicaid on Tuesdays, and Tuesdays is their day off. So to work through all of those issues are something that Healthy Communities would take care of. The point that CMS wanted me to also make is that while we offer transportation and it includes the cost of an ambulance, taxi, bus, or other carrier, it can also include the reimbursement for mileage. And while other services covered through EPSDT, states may cover the least expensive means of transportation if it is actually available, accessible, and appropriate. So a lot of things you'll hear will go back to least costly, but it's not the only thing that a state can use to determine if something is able to be used or not. Diagnostic services under EPSDT are when a screening examination indicates the need for further evaluation, diagnostic services must be provided. A referral should be made without delay. A primary care practitioner conducting the screening needs to refer the patient to another specialist or subspecialist to allow for further evaluation and diagnosis. There should be a follow-up to ensure that the child receives that evaluation to a PCP. We have a federal mandated reporting called an EPSDT CMS 416. Again, a lot of acronyms. We call it the 416 report. It's due on April 1st of every year. And while you would think that that report would report back to CMS on all services so we can get a good look at a child, again, it was developed in '68, redone in '89. So what we have to report on are the number of screenings provided, the number of referrals given, oral health services, and lead screening. We don't talk about immunizations, we don't talk about developmental, and we really don't have a good way or good direction out of CMS to track referrals. So really what CMS has asked us to do is to look and see if the child has had any other follow-up care after that PCP visit within 6 months, which is a long time. And if so, that is counted as a referral. If you really go back and look at the 416 report closely, please don't take that line as gospel, because we're in the middle of trying to redo it with CMS right now, and it really is meaningless. Hopefully, as we get going with ICD-10 and redoing the report that way, we'll be able to report more data on referrals, but right now we know that referrals are not working. We know that they're not getting them. Providers say wait and see. They get them, they don't go. Nobody's following up. So all of those things will hopefully be fixed with accountable care, with PCP, with medical homes, and hopefully we'll be able to do some better reporting on that in the near future. Treatment services under EPSDT. So this is really where medical necessity comes in. And healthcare must be made available for treatment or other measures to correct or improve or ameliorate illnesses or diagnoses covered by the screening services. All Medicaid coverable medically necessary services must be provided even if they're not available under the state plan to other Medicaid eligibles. So what this means is we call them as EPSDT exceptions. So a really good example is if we wanted to go back to that optional covered service and take out oral health. And we just said, okay, it's an optional covered services. The state wants to save $65 million. We're taking it out. All of those services can be seen as medically necessary, so they would all become EPSDT exceptions, even if it's not in the state plan. Even if you approved it not being in the state plan, even if somebody else approved it not being in the state plan, it is a covered service, therefore it would have to be paid for, and we'd have to have providers to serve. The state may require pre-authorization for treatment based on screening, exam, and diagnosis. States may impose utilization controls to safeguard against unnecessary use of care and services. A state may establish tentative limits on all amounts of prescribed healthcare treatment services a child can receive and require pre-authorization for coverage of medically necessary services above those limits. Prior authorization must be conducted on a case-by-case basis, evaluating each child's needs individually. Prior authorization procedures may not delay delivery of needed services and must be consistent with the preventative thrust of EPSDT. Prior authorization may not be required for any periodic or interperiodic screening services under the EPSDT benefit. In addition, medical management techniques such as those used by MCOs for mental health and substance use disorders should comply with the Mental Health Parity and Addiction Equity Act. Each state has a process for prior authorization services, whether directly through the state or in a fee-for-service delivery system or through a managed care plan in which the child is enrolled. There are, to be no hard limits such as hourly caps. Soft limits are permissible as long as there is a statement identifying that children can receive services in excess of the limits set forth in the plan. A way to think about that is if you look at our substance abuse benefit, it does say that there's a limit of 35 visits per year. Right after that, it says with the exception of children under EPSDT. So again, the limit is there with the exception. A state may not deny medically necessary treatments to a child based on cost alone, but may consider the relative cost effectiveness of alternatives as part of the prior authorization process. Also, a state need not make services available in every possible setting as long as the services are reasonably available through the settings where the service is actually offered. We did have a conversation in our meeting with CMS about residential treatment and the Olmstead. One does not preclude the other. So if a child needs to go into residential treatment, we can't use Olmstead to say, no, they can't go. If they need to be at home, we can't use Olmstead to say, well, really, they need to be over here. So we had a long discussion about that. It does come back to the appropriateness of where the service is needed and the appropriate setting. All states were like Colorado in that we do have some children who still do need residential services, and unfortunately a lot of those children end up going to certain facilities in certain states, and so a lot of children end up leaving their home state. CMS does not consider that a violation of Olmstead because under EPSDT we are required to provide the service in the area where they need it. Medically necessary is state-defined. There is no federal definition. Under E EPSDT, a state must cover all medically necessary services that are mandatory in 1905A that we talked about earlier. And EPSDT entitles children to any treatment or procedure that fits within one of the categories in 1905A, even if that treatment or service is necessary to correct or ameliorate defects in physical and mental illnesses or conditions identified by screens. Please know that that's CMS language. Do not tell me it's not first person. They know. They heard it a lot from us. States are permitted but not required to set parameters that apply to the determination of medical necessity in individual cases, but those parameters may not contradict or be more restrictive than the federal EPSDT requirement. In states where health care is delivered to enrolled children through managed care organizations such as MCOs, the MCOs must make medical necessity determinations according to parameters set by the state or according to the federal statutory requirements if the state has not adopted its own parameters. There is also a website, the National Association of State Health Policy, where you can find a lot of this information. NASHP works very closely with CMS, and so all of the documents that we talk about, along with the definitions of medical necessity and what other states are doing, can be found on that NASHP website. It is in your PowerPoints, but we're not going to go to it, so I can save you some time before lunch. A service need not cure a condition in order to be covered by or under EPSDT. Services that maintain or improve the child's current health condition are also included within EPSDT scopes because they ameliorate a condition. Here's another thing that the feds wanted to point out. A common definition of ameliorate is to make more tolerable. So if we think of ameliorate and we think of make more tolerable, it fits in a lot of situations. We do have a prior authorization process with APS. Judy's been great in helping us get that up and running with them over the last year. On average right now, they make about 9 EPSDT exceptions on their own a quarter. Those are for services such as circumcisions, so even though you all took circumcisions out of the state plan, it is medically necessary for some children, and so those are being approved through a process with APS. On top of that, EPSDT itself has approved 14 more. Most of these are for pharmacy. Those do not go through APS. For personal care. And for the Baja type equipment that was previously a closed benefit, but because of the numbers of requests that were medically necessary, Judy did make the determination to go ahead and open those as an open benefit. That way it saved everybody from having to go through that extra step. The other part of medically necessary, along with not covering services or items which are experimental or investigational, is that we also cannot cover services for the parental or provider convenience. A good way to look at this is that if I'm a physical therapist and I see children 0 to 3, so I go to their homes, and when I start out in the morning, everything's clean. I go to the first house, I do my therapy, I come out, I go to the next house. Before I go in, I have to clean everything off. In order to keep with regulations, that's a long process. It can take 35 to 45 minutes to do that. It would be really easier for me as a therapist if every child had a set of toys, so I could just walk in and just complete that service and walk back out. If those toys are not appropriate for that child, then it won't be covered because, again, it's for the convenience of the therapist and not for the child. Now, that is clearly not to say that we will not approve therapy toys to stay home with the child, but they need to be medically appropriate, and the therapist will need to say, I am going to train the parent, the family, the caregiver, whoever, to use these when I'm not here. So again, they're covered just at the convenience of the child's treatment, not at the convenience of the provider's treatment. States must also include periodicity schedules. So as you know, back in April when we were here talking about the EPSDT rule at that time, we talked about adopting Bright Futures. And that has been fully adopted. We have also kept in place what used to be called the EPSDT Steering Committee. It's now called the Children's Services Steering Committee. And that is our recognized medical and dental professionals who work with us on all of the projects, such as adopting the periodicity schedule, looking at rules and regulations. Right now we're actually looking at, do we need to do more screenings during well care. So we have a request that's come in to do social emotional screenings at every well care visit from birth to 20. So that group is looking at that. Some of the recognized professionals on that Children's Services Steering Committee include Doctors Talmy, Wells, Campbell, and Betts. So we have pediatrics, behavioral health, developmental pediatrician, AAP, all represented on that. The state is also required to come up with a dental periodicity schedule. That has actually been posted on the dental site for a little over 2 years now, and I'm sure will be looked at with the new ACO process. You will often hear us talk about interperiodic visits. If you think of these as sick care visits, so we have our well care, our screening. We also cover interperiodic visits, so suspected illness or condition, so a fever, a toothache, the flu, broken finger, all of those are interperiodic, and all of those are also covered. They, again, as we heard earlier, must be based on self-referral, so even though we can put prior authorizations in, it cannot be for the EPSDT well child check or any of those screenings in between. Some of the providers who provide EPSDT services can be physicians, nurse practitioners, physician's assistants, dentists, hygienists, OT/PT speech therapists, and clinics, school-based settings. They're all EPSDT providers. Some states actually have separate certification for EPSDT. We took a lot of this back out in 2003 because we saw it became a barrier to care. So even though I had a physician who was doing a well child check, they weren't a certified EPSDT physician, so it didn't count. Even though I had a dentist that I was going to every 6 months, they weren't EPSDT, it didn't count. We used to have to actually have an EPSDT screening form that providers had to fill out. Number one, it became another piece of paper that the provider had to fill out and turn into the state, and we had to keep track of. But that form was also becoming a barrier to getting additional services, and so we removed that in 2003 also. EPSDT, because it is a state system, will look different state to state. Some states still have that EPSDT form, some states still have that EPSDT certification. Ward is not one of them. We do have special guidelines that you all approved in the EPSDT rule around managed care. We wanted to make it clear as to what managed care was responsible for doing. What we find out is when we put something in the contract that says must follow all EPSDT regulations, they say check, and then they have no idea what that means. So thanks to you all, we've made that clear in the EPSDT rule. That's going down to the managed care contracts, and so we're getting them on board also. Another piece that CMS and I talked about is the overlap between EPSDT and the waivers. We think that there's some misunderstandings, at least in some states, about how EPSDT and the waivers work. So, as you know, waivers must be the primary vehicle for non-institutional services for individuals with significant disabilities. They must be cost neutral, and to be enrolled, individuals must meet an institutional level of care. What sometimes happens is that parents and providers think that once a child is on a waiver, they don't have access to EPSDT. Well, the very first service in a waiver is access to Medicaid state plan benefits, which includes EPSDT, includes all those overrides and medically necessary services that we talked about. What doesn't happen is the reverse. EPSDT cannot be used to override the benefit limits on the waivered services themselves. So EPSDT cannot be used to override the $35,000 cap for CES. EPSDT cannot be used to override the $10,000 limit for home modifications. So EPSDT can still be given to a child and will be given to a child when they're in the waiver, but know that EPSDT is only there to be the exception for the state plan benefits, not the waiver benefits. Does that make sense? I see heads nodding. We also do have an inpatient psych under 21. This is really honestly the PRTF piece. A lot of states do not have this and use it as an EPSDT exception. We actually have the availability in our state, so it's not even known as an EPSDT exception just because it's out there and available. Every child has the same appeal rights when they're asking for an EPSDT exception as they do for any other benefit. So if I say that, again, let's go back to totally hypothetical. I'm a physical therapist, and I say that this child needs 100 visits from me a month. I can ask. I can say, I believe 100 is necessary. I need an EPSDT exception. It's the same appeal process. So the family would go through the same appeal process to try to get those 100 visits as they would if they're just trying to get 2. There's no separate process for that. We have very specific information on how that works. And we do actually tell families, if you're going to go in and appeal, then you need to start quoting EPSDT. If you want to go above and beyond, then quote EPSDT in your appeal packet so the administrative law judge knows what you're looking at and why you're asking. So again, we can become the overriding factor in limits on benefits. We can become the overriding factor in if something's not offered but is medically necessary, like a circumcision. We cannot approve things that are experimental or investigational for the convenience of the provider or the caregiver, and we cannot use cost as the sole factor in determining if something's medically necessary or not. Other than that, EPSDT is a pretty wide open program. It does come back to the states to determine medically necessary services. Everybody keeps saying, well, we need the Fed's definition. There isn't one. States are allowed to determine that. That also is why EPSDT looks different state to state. We have parents come here saying, I could get this there, I can't get it here. This is open there, it's not open here. I could get on Medicaid there, I can't get on Medicaid here. I could get a waiver there, I can't get a waiver here. It's all set up state by state. So we try not to look at what other states provide in the ways of benefits, and we get a ton of calls from parents who want to move here going, okay, what's your benefit? How can I get? What's the waiver system like? How do I use it? What do I do? Because they're shopping and searching for another place to be able to take their child where they can get the same services. We have parents choose to move here. We have parents choose not to move here. We have parents looking to move out of state who choose to stay here. Does that help? Does that help with your conversations around medical necessity, why we talk about it, EPSDT? Christy's got her lips going. I know she has a question.
Not a question. I have a small correction, and it happened today. The home modification went up from 10,000 to 12,500 so anyway, I'm just correcting that. But for the board members, just to help understand why I asked for us to do this, had to do with understanding better the personal care and the framework around the personal care tool next month, and why, because that's all coming forward because of EPSDT and the federal mandate.
And personal care actually is listed in 1905, but again, as it applies to medical necessity, that goes back to the state.
Any questions for Gina?
The littlest people and the most complex.
That's very, thank you very much.
Sure.
Appreciate that. All right, Suzanne, department update. You are between us and lunch now.
I won't keep you long, so just a couple things to update you on. So the first thing is we're now 36 days away from the next open enrollment period, and we've been really gearing up for that. I did want to remind everyone that more than 400,000 Coloradans have enrolled in health coverage since October of last year. And these Coloradans are covered for and are using important benefits like doctor's visits, dental visits, hospitalizations, prescriptions, and preventative care. I want to remind you that we're continuing real-time eligibility determinations so consumers can find out if they qualify for Medicaid or CHIP Plus more quickly. And this means applicants who complete their online application completely and accurately, and that is highlighted in my notes, may find out immediately if they qualify for Medicaid, CHIP Plus, or tax credit. And very exciting, starting this fall, Coloradans can complete a single application to learn if they qualify for Medicaid or CHIP Plus, or if they qualify for an APTC through the marketplace. So one application between us and Connect for Health Colorado.
Do we know when this fall?
It's November 15th. We've also worked to align member account sign-on functionality of Colorado.gov Peak and ConnectForHealthColorado.com. And consumers will be able to sign into their Peak or Connect for Health Colorado account using the same login and password. So they don't have to have a separate login password for Peak and a separate one for Connect for Health. They can use the same one between both systems. Okay. Applicants will get joint letters from the Department of Healthcare Policy and Financing and Connect for Health Colorado. That's another big improvement because I can see that clients would get different letters that they would find very confusing. Did want to point out that we're fortunate in Colorado to have had a successful first open enrollment period, and we were recognized as one of the top 5 states in reducing the number of uninsured. So Colorado's been a national leader, and we expect that to continue. I want to point out that next Tuesday and Wednesday, the department is collaborating with the Colorado Health Foundation, Connect for Health Colorado, and the Division of Insurance to host the Building Better Health Conference. And the conference aims to promote improved coordination and collaboration among those who are enrolling Coloradans in health insurance. More than 850 health coverage guides, assistant site navigators, certified application counselors, brokers, agents, community-based organizations, and health advocates are signed up to attend. So that's quite a number of people.
When is this conference?
When is it?
Tuesday, when it was?
It's Tuesday and Wednesday.
Where?
And I don't know where it is. We can get you that information, but it's called Building Better Health Conference. We can send that out to you. And you might have seen last week that we announced that Jed Ziegenhagen is going to be the office director for the Office of Community Living, which is very exciting. Jed's new role begins October 1st, which began October 1st. And the goal of this newly formed office is to provide strategic direction on the redesign of all aspects of long-term services and supports, including service models, payment structures, data systems, and to really focus on making the system person-centered. And Jed's been doing LTSS Division Director for about a year and a half, and he's done a great job. And he's assembled a really good team, as you've seen even today testifying. So we expect that work to continue. Their big priority will be implementing the recommendations of the Community Living Advisory Group, which is going to be no small feat. A big part of that will really be developing an overall project plan and a project schedule for all of the moving parts coming out of the CLAG and those recommendations. So it's very, very complicated body of work, and it's going to be a multi-year effort. I did want to point out, some of you might recall that there was something called the primary care rate increase included in the Affordable Care Act, and it essentially took office visits and vaccinations up to the Medicare rate. And that was set to expire December 31st of this year, and the legislature passed funding to essentially continue that. So that is a big success for us and for our providers. I think that's it. Those are the highlights this month. Any questions or comments?
Great. You had talked about the presentations day. I thought the presentations for the rules today were really well done.
Mm-hmm.
I think you can pass that on to them and stuff that.
Thanks, Suzanne. And thank you for keeping us on track.
But no, I thought they were very good presentations. Okay, the last thing on our agenda is election of officers. And Judy, I have no idea how we do this, so.
You just take nominations from the group and vote.
So we have 2 officers, is that right?
We do.
What is it, chair and vice chair, or what do they call it?
President and vice president.
President and vice president. So looking for, I guess, nominations, start with the president, I guess. Nominations for the presidency role.
Who's our vice chair?
Ms. Lacombe.
I nominate Brenda Lacombe for the president position.
I'm ready to take on the role. I just think that Mike has done such an amazing job. We were the 2 rookies that came in together, so I think we bonded. And it was interesting to be up here together as well. So I am happy to take it on, but I think Mike's done an amazing job, and I also recommend you can stay on. So
Mike, are you willing to stay on?
Are you willing to stay on, Mike? If not, I will succeed you.
I could do one more year. I don't
I
mind.
withdraw my nomination. I nominate Mike Stahl for the president.
See, Donna doesn't second that one, though.
No, actually, I was about to say, I will second that,
Mhm.
and I will nominate you as vice chair or vice president.
Okay,
I accept
you're
that
nominating
position.
Brenda
And
as second.
I was just gonna say, I
Yeah.
would suggest we stay status quo.
You know, and I think that Mike made a good comment earlier, that it does take us a year in this role
It does.
to really get comfortable, to say, okay, I think I got it, and then we're off. So, yeah, so I agree. One more year.
Do we have a second on that?
Oh, second, sorry.
So it sounds
Yes.
to me like we have a nomination of myself being president for one more year, and Brenda being the vice president this next year. We have a motion and a second on that. Any other nominations that people want to throw out there? Any other nominations? With that then, all in favor of that slate of officers, please signify by saying aye.
Aye.
Dr. Young? Dr. Gibbons?
She had to sign
She had to sign off. Mr. Fox?
Aye.
All righty, we have officers for another year. And
Could
with
I-
that,
Mr. President, could I make one quick announcement? There's been discussion between the Department of Healthcare Policy and Financing, Department of Human Services, and CDPHE, Department of Public Health and Environment, to have a collaborative meeting between the three boards. So it's Board of Health, Medical Services Board, and State Board of Human Services in January.
Can I suggest something else? Since Connect for Health Colorado, and not, I'm kind of keeping out of it, they're a new player because we are sharing the system with Connect for Health Colorado right now. And I don't know if you think about considering adding that board as well to the
I will
collaboration.
take that back.
Okay.
This is coming down from the executive committee, so, but I will offer that up to them.
Right.
Currently, the plan is between the three executive directors for it to be the three boards. So I'm just asking you to save the date of January 21st. It will be in the afternoon, probably about a 12:30 to 4:30 or 5. Wednesday, January 21st. So a lot of preparation still needs to be done. This is just to kind of save the date.
you're saying in the afternoon,
Yes,
till how late?
probably 4:30.
So a Wednesday.
Yes.
Okay, just checking.
And the focuses of this is what again, Judy?
Well, and again, this is very preliminary, but I would say that the theme sort of is Colorado working together. And so a lot of the focus is going to be how these three sister departments have collaborated, how Ms. Birch and Mr. Bika and Dr. Wolk have, they meet regularly, and they just discuss the sort of overlapping. I think for a long time there was an impression that Human Services did one thing and Public Health did something and we did, and we never talked to each other. And so they're really trying to do a lot of alignment and collaboration. So I think that's going to be a lot of the focus. There will be some information on Affordable Care Act. The state, have they awarded the SIM grant?
Not yet.
Okay, so we have applied for a state innovation model grant, which is a pretty large number. 70, it's
Somewhere between, I forget, 60, 90 million.
yeah. So we will know before then whether that was awarded, so there'll be some information on that. I'm sorry, the information I have is a little sketchy right now, but.
Can I throw it out?
Yes.
So, we're doing a lot to transform healthcare, and that has ripple effects both between us and Department of Human Services and CDPHE. In particular around roles. A lot of the work we're doing around person-centeredness And for example, the new CMS rules around HCBS, homeland criteria, really, that impacts CDPHE. And so I think it's important for the boards to all understand what are the different priorities of the department. So as rules have to touch us and them, that we're all in alignment and we can make sure that things are flowing smoothly.
All right. Very good. Anything else for the good of the order? Otherwise, we have sandwiches here. And we're adjourned. Thank you all.
That was my
That's good.
I think his term.
Great.
And he was on longer than me, so he probably was term.
Okay. Okay.
Thank you.
Who was term? I never wanted to take a leadership role. I just don't know.
And I
I mean, I'm not
apologize,
going to
everyone,
nominate
for the
myself,
sound
but I'm
issues
willing to
today.
do it.
Trying to get it-
I just,
trying to get it
Richard.
worked out.
Andy, welcome.
Richard,
Thank
yeah,
you.
yes.
Thanks
Okay,
very much.
yeah, I was curious.
Yeah, survived the first one.
Technically, there are no term limits for medical services board. It is at the pleasure of the governor. And Governor Hickenlooper has implemented a policy where he's not reappointing board members who serve.
Take care as well.
All right, I didn't know. Yeah. So, okay, all right. And just so you know, I'm receiving texts, yes, from people to make sure I say things that I'm supposed to say or think about. So I don't miss it.
He's so nice.
I'm all worried about that. I'm very steadfast in what I know and what I do, so.
You have been a good member.
I'm trying. And we do look forward to you moving into a leadership role. Oh, okay.
Yes, ma'am.
There's some.
I'm just gonna run to the
All
restroom.
right.
And what will be in
I also received texts from the family,
Yeah.
Lauren's caregivers and things like that.
Put them in place way back.
Finally looked at my husband